Great. So I think we might want to start because we are about 5 minutes before the 8:30. So I would like Eileen or and Will to kind of give the introduction. They were the uh, original creators of this exciting event. So thank you, Eileen and Will, for having this great idea of having a workshop. So I'll let you guys start, and then we'll start into the first session.
Well, I don't have a lot to say. Hiram has taken over my job of organizing this for the USC half, and UCLA half, sorry. We're a joint center sponsored by NIA, and Hiram has really done the work this year, so he deserves the credit. And this is an undertaking Will and I have done now for, is this the seventh year or something,
I think
Will?
this is the ninth
The
one.
ninth? Okay. And we actually enjoy it, and it seems like a very useful way to get people together who work on these topics. So I think we will continue this in perpetuity. We'll see how the day goes. Anyway, Will, you have anything to say?
Yeah, well, thank you again to Hiram for has done a lot of the heavy lifting this year. Really appreciate that, and to the staff, John Key Kim has been super helpful. Thank all of you who are here, and this
Yeah.
is really for you. Eileen and I created this as an in-person workshop when we first started. I think back in 2017
The
or
old
so,
days.
and it was great in person, but we've been able to include so many more people from around the world, and there are many people logging in from low and middle income countries, which is exactly what we want and need in this. So welcome to everyone. There's a great mix of topics on the program from mortality and health determinants, a mix of disciplines here, so we get that crosstalk. There's a great mix of early career folks and then more seasoned folks that can help both in terms of the presentations and the discussants. So some more early exploratory work, some much more polished work, mix across countries, continents. So, part of the goal here is just to support, all of you who are doing this fantastic work and continue to build the body of research, which is taking advantage of so many more population-based studies of aging that we have now. There's health and retirement surveys around the world, and then many other sister studies that are now collecting these data increasingly with mortality, although mortality is it's been a challenge to have good follow-ups in many of these data sets, but we're learning so much from studying the determinants of mortality. I want to thank the NIA for their support. So NIA is supporting our centers. So at Berkeley, it's the Center for Economics and Demography of Aging. Our program officer, Minky Chatterjee, may be here at some point, but I don't think she's going to give any introductions today. And NIA is supporting the USC UCLA Center as well, which is great. So we have a large number of people on Zoom. Many more people have registered, so people will be coming in and out throughout the day. Uh, we do want to have conversation though, so use the chat liberally. We'll share the chat streams with the authors. So if you have comments and questions, and we can use that for the Q&A portion. And if there are co-authors here, then feel free to engage in the chat, sort of answering questions in real time during the presentations. So when we get to the discussion portion, we'll have a discussant give some formal comments, and then we'll open it up to the group. And so ideally, you can raise your Zoom hand. If you can't find your Zoom hand, come on camera and raise your actual hand, and we'll sort of get to you. And we will be recording this throughout the day and sharing it online. Although if there's a few presentations that the presenter said that it's not ready for sharing, and so we will not share those portions. And I think in the past we've been able to edit out the discussion portion too, so people feel a little bit freer to engage in that discussion. So we're at 8:30. So thank you, everyone. Hiram.
Yes, thank you, Will, and thank you, Eileen. It's great that we have continue to have this workshop. Thank you for both, and thank you, as they mentioned, to NIA for the support that they have provided, and to John Key, who helped me quite a lot with the organization. So throughout the day, I send an email to presenters that you will have about 12 minutes. For the very first session, we have one in-person speaker that was unable to attend today. So that gives the presenters about 15 minutes. So you guys have a little bit more time. So I'll keep track of that. So this is just to keep with the same schedule. We want to end the session, about 10 minutes before 10 or so in Pacific time. So we continue with the second session kind of in the time that we already scheduled. So then for today, for the first session on chronic disease, we have 3 presenters. So you guys should be able to share your screen and unmute yourself as we go on. I'm going to keep track of the time. So I'll let you know when we are about 2 minutes before the 15-minute count, so we can sort of keep within the schedule that we already have. So it's, again, very exciting to see everybody. So we have over 45 people, so that's great. So hopefully we'll keep having more people, as at least in the Pacific area. We get a little bit later into the time. So without further ado, let's start then with the first session. Welcome everyone. So this is going to be the session on chronic disease. So we have so the next talk is by Ralph Lawton from Harvard University. This is on sustained impacts of stress on thyroid function and cardiometabolic health. These are 20 years after the 2004 Indian Ocean tsunami. So, Ralph.
Yeah, good morning, everybody. Let me share my screen here. Let's put it up.
Great.
Okay. Well, thank you all for being here this morning. My name is Ralph Lawton. I'm currently an MD PhD student at Harvard. As a joint work with Duncan Thomas, Elizabeth Frankenberg, Churchip Samantri, Teresa Seaman, Eileen Crimmins, and Daniel Hochbaum. And the talk is entitled Sustained Impacts of Stress on Thyroid Function and Cardiometabolic Health, 20 years after the 2004 Indian Ocean tsunami. Now, the motivation for this talk is fairly broad, right? I think we have a lot of evidence that suggests cardiometabolic disease responds to stressful exposures in the short term and even into the longer term, right? Oftentimes, the HPA axis and the cortisol response is implicated in this, but other endocrine axes are not really understood very well and are potentially implicated and potentially important, right? We focus here on thyroid function because it is, 1, a key element of cardiometabolic health, and 2, not very well studied. There's very, very little evidence on the long-term impacts of stressors on thyroid function in general. What we're going to try and do in this paper is first provide new evidence on the effects of long-term impacts of stress on thyroid function. We're going to focus here on free T3, which is the active hormone in the thyroid axis. At the same time, we're going to show causal evidence on the impacts of tsunami exposure on cardiometabolic health. We'll examine biomarkers measured over 20 years after the time of the tsunami and link back to exposures, again, 20 years in the past from prior survey data. To preview our results for the day, we're going to show that tsunami exposures associated with long-term reductions in free T3, so lower thyroid function, and worsening cardiometabolic health. The point estimate signs are going to suggest that thyroid function might actually be upstream and contributing to some of these other metabolic health changes. The data we're going to draw from is going to be the study of tsunami aftermath and recovery, or STAR. As the name suggests, it follows a big tsunami that occurred in 2004 and follows those individuals into the long term. So the study design builds in wave 0 here on data collected by Statistics Indonesia. So they ran a big survey similar to, I guess, the American Community Survey, but in Indonesia. The tsunami happened in that December, and those individuals have been tracked annually and then now out into the long term. Right? We're going to focus here today on this 20-year data on the right side here. The main survey is 27,000 baseline respondents tracking migrants, so we'll kind of follow people as they move away from the baseline communities with very high response rates. So there's 93% re-interview rate in every wave since the baseline. Our data today is going to be from the 20-year extended assessment of biomarkers and cognition. So it's a 1/4 random subsample of the main sample, trying to do more detailed measures of blood biomarkers and cognitive health. This will leave us with 3,270 adults aged 35 and older at the time of measurement, who had been 15 and older at the time of the tsunami. So people who would have been in early adulthood and onwards from the time of tsunami exposure. And since this is our first time doing thyroid markers in the wave 20, we're going to be taking one wave of thyroid markers and linking them again to those exposures assessed based on tsunami location 20 years ago from the earlier survey data. So a quick primer on thyroid function, because I think very few people are in relative terms familiar with it. It doesn't get as much attention as some of the other endocrine axes. Hypothalamic pituitary thyroid, or HPT axis, focuses on energy expenditure and metabolism. It's this little organ on the front of your throat here. Among infants and very young children, you hear about it for brain development. But among adults, we think it's really more key for metabolism, right? Metabolism, temperature regulation, these sorts of core metabolic activities. Implicated with slowing metabolism with aging. And the relationships to long-term stress is unclear, especially for free T3. The literature is small and what's there is mixed. I'll do a quick walkthrough here just because people are often familiar with different parts of this chain, right? So you'll see kind of a chain of hormones that make up this axis. On the left side here, you have TSH, thyroid stimulating hormone, which, as the name suggests, stimulates the thyroid to secrete free T4, which is a pro-hormone, which in the periphery of the body is converted to T3 by these deiodinase enzymes, right? The key here is that T3 is the active hormone in this chain, right? This entire chain of hormones exists to make T3 conduct the activities that we want the thyroid to actually do, right? And TSH is the upstream clinical biomarker. The reason I try and draw these distinctions is that if you are familiar at all with the thyroid axis, you might know that TSH is the primary clinical biomarker. And while it's probably decent at stratifying out overt clinical extremes, it doesn't seem to be, at least in some work that Daniel and I did before, terribly predictive of much of the thyroid functions we'd be expecting in the normal population, right? People who aren't in an overt disease state. Whereas free T3, we think, is potentially a better measure of the sort of general population thyroid function. So we're going to really be focusing here today. Now, there's not many samples that measure free T3 outside the US. So we're going to just do some quick descriptives on how this looks in Indonesia versus the US. And the headline here is that we see similar age and sex relationships in STAR. We focus on those who are not exposed to the tsunami, is just to avoid any confounding there. And compare them with the NHANES samples from the US. And you see a couple kind of big things here, right? First of all, is that the males in blue tend to have higher levels of T3 than women, which is standard. And we see a similar thing in Indonesia. We also see a pretty quick decline with age, right? Again, this is slowing metabolism with age. We see the same things in STAR on the right as we do in the US, but the age slopes aren't quite as steep. I admittedly don't have a great explanation for why the slopes would be different, but I think at a high level here, we're seeing similar demographic and age relationships with T3 that we see in our reference group in the US. So we think we're actually measuring something real here. Now we'll draw comparisons between free T3 and some other biomarkers of interest. We'll focus on some cardiometabolic disease biomarkers. We'll have non-HDL cholesterol, HDL cholesterol, HbA1c for diabetes, diastolic blood pressure, systolic blood pressure, and BMI. And we're going to take all these and put them together into one big index. We'll make a cardiometabolic diseases index as an inverse covariance weighted index in the Anderson style. And that'll look like this. So you'll see by males and females, males are in blue, females are in red. The disease index is increasing until about age 60 and then declines as BMIs start to fall off in older ages. That's really what's driving that kind of U-shape there. So we'll draw comparisons between this kind of compound outcome and our T3 measure. Now, our exposure of interest is the 2004 Indian Ocean tsunami. For those of you who weren't familiar or potentially were a bit younger when it happened, it was a huge natural disaster. It was a 9.1 Richter scale earthquake, weighed up to 30 meters high, and consequences that ricocheted around the entire Indian Ocean basin. A huge kind of catastrophe. Two features are important for our empirical analysis of its long-term consequences, right? One of which is that the tsunami was unanticipated. While there's a lot of tsunamis in Indonesia on the Pacific Ocean side, where there's a lot of volcanoes and sort of classic ring of fire around the Pacific, on the western side, on the Indian Ocean, there hadn't been a tsunami in over 600 years, right? So there's really no expectation of this, no early warning systems. On top of that, exposure is very idiosyncratic, right? Depends a lot on where were you relative to where the epicenter was, as well as topography of the seafloor and the land, right? So you can imagine if you're on one side of a promontory versus another, and the waves are coming from one direction, you'll get very different exposure to the actual tsunami's consequences. And that kind of local variation we're going to try and leverage here. Our exposure is going to be operationalized as the mortality rate in the coastal communities you're residing in at the time of the tsunami, right? So remember, we're going to be linking these 20-year outcomes to where you were living at the time of the baseline and bring that kind of community mortality rates as our treatment of interest. Now, you can imagine that the west and the east coast of the islands were hit differently. We don't really want to make those comparisons. We want to focus on the sort of local, where you're living on one side of a promontory versus another type of comparisons, right? So to do that, we're going to have a district fixed effect, to kind of do this within district estimate, as well as controls for geography with elevation and distance to controls. And we think between the unanticipated nature and the idiosyncratic level nature of exposure, we think this is a plausibly exogenous treatment. And I'll show you some evidence for that later on too. To make this a little bit more concrete, we have here a map of our STAR study sites. So you see a couple things here. First of all is that we're really only looking at coastal communities. Right? We're not really looking at the mountain communities that run up the spine of the island. The other thing here is that there's a lot of overlap between communities that are heavily damaged and those that were not. We blow this up for you guys in a panel on the right here, where you see within a 5-kilometer band, a pretty small geographic area, you have a lot of variation in communities that were pretty much entirely damaged and wiped away, and communities that had much less tsunami exposure, right? And it's this local variation we're going to try and use to trace out the long-term impacts and further along. Now, exposure of interest is the percent dead in the baseline community, right? And it looks a lot like this. So we've got a lot of mass at 0 for places that weren't really affected. We have a lot of mass between like kind of 5 and 10%, right? In places that had significant damage, like a 5% mortality rate, still a lot of mortality in a tsunami event. And then we have a very long right tail as communities get really heavily exposed. In order to try and address this, we're going to use a quarter group transformation to retain our mass at 0, right? Because a log would drop the mass at 0 and kind of pull in this long right tail, something a little bit more tractable. We'll estimate this regression here, look at Chamotan district fixed effect. As I mentioned before, we want to kind of be looking at variation across communities, but within smaller districts of Indonesia, including other controls for geography, age, and SCS. Now finally move on to our outcomes here. I'll show you the outcomes from that regression that we just showed you before. And we have a forest plot that'll show you the beta coefficient from that regression with a confidence interval for all of our different outcomes here. Right? So the first off is we have our free T3 marker. And what you see is that tsunami exposure is linked to big declines in free T3 metabolic function in the long term. Right? So we have thyroid function reduced 20 years after this tsunami exposure. At the same time, we see increases in our metabolic disease index. Right? So we're seeing decreases in our thyroid function and increases in the metabolic disease index, suggesting worse cardiometabolic health. You see for all of our components, most of these markers are off to the right side of this. And then on the bottom here, we have our balance checks. We have like a little bit more evidence that the tsunami exposure we're thinking about actually was exogenous. So we have here the relationship between tsunami exposure and baseline characteristics, and there's no relationship between sex, age, height, which is important for health here, years of education, or per capita expenditure, a measure of economic resources. So what we're seeing again is impacts long-term on thyroid function and metabolic health, but very little on the sort of kind of placebo checks that we'd be worried about. Now, interpreting these results, I think there's something interesting you can say here from the directions of the science, right? And you can imagine a mental model here where free T3 and body composition often have this circular relationship, right? To make an example, if you're, say, running a calorie surplus, you will both raise your free T3 to kind of raise your metabolism and spend that surplus down and increase your adiposity. So these things will often move in tandem when T3 is responding to BMI, if that makes sense. On the flip side, if you had an exogenous change in T3, if we raise your metabolism, your BMI would fall, right? And that's what you're actually seeing here, this directional. We're seeing BMI going a different direction from the T3, the free T3 results. Right? Our disease index is going a different direction. So just potentially that central slower metabolic rate might actually be meeting to some extent some of our other outcomes that we see, right? Potentially these T3 changes are upstream of these other metabolic changes we're also seeing. Now, we did a little bit of examination of some heterogeneity. So we tried to estimate parametrically what is the effect of tsunami exposure for people at different ages of the survey, right? What you see here on the left is our free T3 plot, and on the right is for the metabolic index. And you see similar things, right? The effect sizes get much more negative for free T3 with higher age, and much more positive for the metabolic index, disease index with age, right? So we're seeing emerging effects happening at older ages and potentially emerging risks as people continue to age in this sample, right? It's kind of interesting and important to be following these people 20 years as these risks continue to emerge with age. And finally, we kind of had this other interesting finding, trying to look at selection versus scarring in this context. As I mentioned before, we have a continuous measure of tsunami exposure based on the fraction dead in the baseline community. And you can see there's a rug on the bottom that shows the density of our sample. And the vast majority of our sample is below 10 or 15% mortality rates. And among those samples, you see this very clear negative relationship between free T3 and tsunami exposure, right? But as you get into the right tail, we have a handful of observations in this kind of much more heavily exposed communities where you start to see the direction changing again. I think what we're seeing here, it's somewhat interesting, is this, again, scarring effect with exposure on the lower end. As you get into really truly extreme exposures, a bit of a selection effect at the time of the tsunami, which I thought was very interesting. Anyway, putting this all together, We take all this to say that we're trying to show new causal evidence on the long-term impacts of stressful exposure on cardiometabolic health and thyroid function. Particularly a novel here is the thyroid angle. The effects appear stronger at older ages, suggesting an emerging effect that'll be important to keep following as people continue to age in this sample. The directions of the impacts between T3 and the other metabolic health markers suggest that T3 changes could be upstream contributing to some of those other metabolic changes that we're seeing. And finally, the results emphasize long-term impacts of stressful exposures and the value of measuring free T3 to examine changes in thyroid function in particular. With that, thank you all for listening. Really appreciate it and excited for your questions.
Thank you, Ralph. So
Thank you.
That's great. Everyone is keeping within the specific time. So that's good. So it's going to give us more time, I guess, for the Q&A once we get to that point. So thank you, Ralph, again. So we're moving then on to presentation number 3. This is by Cássio Turra from CEDEPLAR in Brazil. So this is on mortality and morbidity differentials among older adults in Brazil. This is evidence from longitudinal data. So whenever you're ready, Cássio.
All right. Thank you so much, Iran. Thank you, Will. Thank you, Eileen, and all the organizers of this section. Thanks for having me. So before I start, I think, can you see my screen? Yes. So before I start, I want to apologize to our discussant, David. Sorry, David, for not being able to share the paper in advance. And it's because I only recently began working with this data set for mortality analysis, so the results are still quite fresh. I also want to acknowledge my co-authors, Juliana Mambrini, who has been really central to the analytical work, and Maria Fernanda Lima Costa, who is the principal investigator of ELSI Brazil. Without her leadership, this study simply would not exist. So the starting point for this work was actually a paper by Macinco, by Iran, and other colleagues, using the same data set. And they found weak or non-significant associations between important demographic and also socioeconomic variables with mortality. That result struck me, I must say, as both surprising and worth pursuing more systematically. So my goal here is to begin a more demographic conversation about ELSI and mortality, one focus on the regional differences in mortality, composition, data quality, before we can move into the more conventional health analysis that this Brazilian cohort will certainly support. So let me start with what we expected to find. So I don't know if everyone knows here, where Brazil has very deep regional inequalities. The northern states, closer to the equatorial line, they usually have lower income, lower development levels, less access to health services compared to the southern states. So our starting hypothesis was pretty straightforward. Older adults in the north and northeast should have substantially higher mortality rates than those in the south and southeast. This expectation is grounded in the literature, in the demographic literature. But when we look at the ELSI data, the pattern was surprisingly different. Crude mortality rates were nearly identical across the two main regions, about 12.5 per thousand persons years in both. In the Cox model run by Macinco and colleagues using the same data set, as I said, found also no significant region effect. So the large regional gap we expected simply did not materialize. That's the puzzle that we try to examine here. So we use ELSI Brazilian data. ELSI is the only national representative aging cohort in our country. The baseline interviews were in 2015, 2016, and we have a follow-up through 2023. And these data were linked to the national mortality system in Brazil. After excluding the center-west part of Brazil, because the center-west is more like an average of the two main regions. So for analytical clarity, we excluded the center-west. We had about 80,500 individuals and almost 900 deaths. We use two main exposures here to try to look at this puzzle. Education, categorized in three groups: 0 to 3, 4 to 7, and 8 years, 8 or more years. We need to have in mind that education expansion in Brazil is pretty recently. So older people in Brazil have very low education. And we also use self-rated health, which is categorized as good or fair versus poor or very poor. So we run Cox models using age as the time scale with interaction terms between each exposure in region. And to understand the source of the regional gap, we apply a traditional Kitagawa decomposition, which separates the difference in crude rates into a composition effect and a rate effect. So let's start to look at this paradox. Let's look at the top of the slide. In the northeast, 46% of the older adults have 0 to 3 years of schooling. In the southern states, only 27%, near double. That's what we expected. Great. And this group has a mortality rate of 17 to 18 per thousand in both regions. So more than twice the rate of the most educated groups in both regions. So with such large concentration of people in the highest risk group, we would expect substantially higher crude rates in the northeast regions. But we don't see that. Why? The answer starts to emerge when we look within each educational group. In the middle group, 4 to 7 years of schooling, the northeast has a rate of 9.6 versus 14.1 in southeast. This is a striking reversal in the gradient. So let's look now at self-rated health. It also tells an interesting story. In the northeast, 15% of older adults report poor or very poor health compared to under 10% in the southeast. Again, worse conditions in the northeast. Great. It's what we expected. Self-rated health is, again, also a strong effect here, and something that we expect is not surprising. Self-rated health is a very strong predictor of mortality, regardless of the region in Brazil. The hazard ratio, it's about 2.2 for poor health versus good health. So self-rated health work as a mortality predictor, regardless of where you live in Brazil. So that is consistent with the broader ELSI literature and with the international evidence. Although the rates, when we compare the rates between the two regions, they look slightly higher in the southern regions. Again, here, there's something strange here. So when you use the Kitagawa decomposition, we start to see this mechanism in a more concrete way. For education, the northeast has slightly higher crude rate. That time difference, so the crude rates are very similar, right? The difference of 0.16 is 97% explained by the composition. The rate effect is negligible. For self-rated health, the composition effect pushes mortality up in the northeast by 0.6 because more people there report poor health, as we saw. But the rate effect goes in the opposite direction. pull it down by 0.5. Within each health category, rates are lower, as I showed before, in the Northeast. These two forces nearly cancel out, right? Producing a net difference of only 0.09. So, what is the analytical core of my presentation? In both cases, education and self-rated health, the Northeast and North has worse composition, but within groups, North and Northeast rates tend to be lower. This is surprising. The question is, where exactly does that compensation occur? And what does that tell us, right? So for education, the compensation is selective. It's the lowest education group, 0 to 3 years. In the lowest education group, 0 to 3 years, the Northeast rate is actually higher. But the compensation only appear in the higher education groups. There's a reversal in the gradient. So where Northeast rates are substantially lower. Being educated in Northeast is a much rarer achievement than in the South. So it may be a stronger filter. The people who reach 15 and plus with 8 or more years of schooling in that region, North and Northeast, are likely a particularly robust survival population. This pattern may be consistent with the idea of differential frailty selection at older ages. For self-rated health, the compensation is universal. The Northeast has lower rates in both health groups, among the healthy, among the sick. This uniform pattern across all groups is harder to explain than they compare to the education by select survival alone. There's another explanation that demographers like a lot, and I don't want to conclude here without this explanation. Age misreporting. If people in the Northeast systematically overstate their age, this inflates the denominator person years across all groups, lowering all rates uniformly. Age misreported is well documented in Brazil, particularly in historically poor regions with lower litters, as in the North and Northeast. Also, in early studies, we found that education is also misreported in Brazil, usually inflated by older cohorts over time. We have a paper published in the demographic research showing this. And regarding age misreporting, we have to remember that there is a paper by Preston and colleagues that showed that even in a longitudinal study with linkage mortality data, age misreported can bias the mortality rates. So, to summarize, regional crude rates are surprisingly similar in the LZ Brazilian data, despite great socioeconomic difference we know about in Brazil. And in both exposures, the North and Northeast has worse composition, more low educated people, more people with poor health, which alone would predict higher mortality rates. The within group compensation explains the paradox, and the pattern of that compensation points to 4 mechanisms, as I mentioned. For education, selective compensation, survival selection, but also education misreporting. For self-rated health, universal compensation, maybe age misreported is the most parsimonial explanation here. But linkage quality also matters. Now, I didn't talk about linkage quality before, but linkage quality may matter. In this Brazilian follow-up, we lost over 2,000 people to follow-up. Massinco and colleagues, and I also double-checked, he showed the analysis suggests no systematic bias when we compare the loss to follow-up with those who were followed. But fewer deaths may have been captured in the Northeast where the vital statistics is worse. And they are using vital statistics to link with the ELSI data. So the bottom line, regional disadvantage in Brazil operates mainly through who lives in each region, not through where they live, right? And finally, all four mechanisms point to the same need: more mortality data, more follow-up rounds, better linkage coverage, and age validation tools applied to the ELSI will be, I guess, that's my point, essential to disentangle what's real conversion from what's artifact data artifact. That's where this research agenda should go next. And I hope that this kind of quality analysis will also help researchers to work with the health data later, because I think this is important, since in a very unequal country like Brazil, it's important to measure socioeconomic difference and all kind of stuff. But still, ELSI is a very important data for Brazil. It's our first longitudinal study. It's representative for the whole country. So we really have to value the data and just help to improve the quality. Thank you so much.
Thank you, Casio. Again, thank you everyone for keeping within the time, 15-minute time. So that was great. So now we go into the discussion. So David, I see that you are getting ready. So go for it, David.
Thanks. Thanks, Ron, and Will and Eileen. Thanks for inviting me to be a discussant here. So I'll just have some brief comments, but it was really a pleasure to be able to hear these talks. So a lot of really interesting work that I would just want to dive into briefly. So first of all, on the Hoon Johnson paper, this is super exciting to see this application of the FEM, a version of the FEM model with the MHOS data in Mexico to form the M-foam. So I think if I saw correctly on your list of places, this was the first low and middle income country where there was an adaptation or of that model. So that's a really important step. I hope this is the first of many of those efforts to come over the future. I'll also say, having been a little bit familiar with the FEM and worked with them over the years, I also know how much work this is behind the scenes to put this together. So that's, my biggest point here is just a huge thank you to you and your collaborators on doing this work to really build something that's a resource for other people. So it's interesting empirical work in its own sense, but I think, taking that time and building something that can be shared with other people, and also an example of how this can be done, across countries. So I see a hopeful future here for this to be built by a number of global gateway to aging studies, and appreciate your work to do that, and also Brian and the folks at USC to really build this structure and build this model for doing that. So I think one of the things coming out of this, I actually don't have any critiques of your modeling, really just have some comments or thoughts to offer. One, I think one of the most interesting things to me is just thinking about cross-country interventions and modeling them as an interesting way forward. So something happens in one country, especially low and middle income country, we have questions about how that might work in other places. And we can, instead of just kind of guessing or waving our hands about those generalizations, we can do a little bit better by using some of these microsimulation models to test based on the characteristics of that population of what's going forward. One other thing that stood out, and I'm glad you mentioned detail, that thing that you noticed in your model with obesity declining, that was fascinating to me, and it was useful to then hear your explanation of that. There's probably a number of sensitivity analyses to be done on that, and there's always more work to be done, but that was kind of fascinating to me. One of the things that brings up for me is sort of the potential for any, earlier life extensions to the FEM or the M-foam. the data starts at 50, that's fantastic. But should we start investigating, potential extensions? And does it matter, for example, with obesity, if someone has been, overweight for between the ages of 25 and 50, and maybe they lose weight when they get older, as your model would suggest, but does that carry with it risks that might be important to model? And I think it's an open question. It might not matter. Things might be, absorbed after age 50. But obesity is an interesting example where, having those risk factors prior to age 50, there's obviously an incredible amount of health and aging inequalities that exist at 50. And it may be interesting, to start studying that. Another just question I had, and I'm sure it's something you've struggled with a lot, is finding this sweet spot between sort of a general model that could do the things that I'm talking about here, could be compared across context, with sort of country-specific modifications or adaptations to your model. So I don't have anything specific to say there, but I imagine going forward, that'll be an interesting thing to discuss, what sort of modifications might be important in particular contexts, while still keeping the model so that they can be, comparable in the ways that I think would be really powerful. So again, fantastic work. Really excited to see all of the things that are going to be coming out of that model. So now moving to the Lawton paper, another really fantastic paper, very innovative in biodemography to discover what at a population level might be driving stress. And so, the thing that really stands out to me about this paper that's most exciting is looking at T3, thyroid function. It's actually great. I'm not sure if you're Dr. Lawton yet or soon to be Dr. Lawton, but having someone that's bringing some clinical experience, together with demography and work in economics, together to think about that. When I used to be early in my career as a molecular biologist, and you get from like the people who sold you enzymes. I remember them giving me this table. It was from Boehringer Mannheim of biochemical pathways. And it was this big poster, and what it showed, and it was outdated and simplified, is the thousands of pathways happening in the body that help us be healthy or not healthy. And as biodemographers, out of those tens of thousands of things, we're typically picking out 2 or 3 to look at and feel like we sort of have an understanding of this. So, I see this paper as really chipping away at some other pathways that might be happening to help us get a fuller understanding of the biology of aging and especially as it related to stress. But there's 2 other things I really like about T3 or thyroid function. One is just how well you lay out the biological plausibility of this, and how, this isn't picking some random biomarker from that chart, but something that really might make sense, based on what we understand of the biology. Also something that, in terms of thyroid dysfunction is, has a big population health impact. We have strong priors on that. It's also sort of problems with thyroid function are also increasing at a population level. So from sort of a health and population health perspective, something really important to be looking at. So just really applaud your work to include T3 and really take a look at that, for all of those reasons. A few other things I really like about this work that I think we can all think about when we're doing work in biodemography of aging. One, I really like the comparison with NHANES. I completely agree with your view there. It looks a little different, but it shows enough to me to show what's happening there in Indonesia is a similar enough pattern that we can learn from that more generally. So I really love that comparison with NHANES. I also like you putting T3 in the context of other risk markers, biological risks, other sort of stress risks, to see how it compares and doesn't compare. So I really have very few things to sort of suggest or any critiques. I think it's like fantastic work. Another thing I really liked is you do a fantastic job of defending how plausibly random this exposure is. I actually, I've seen presentations on the STAR data before. I don't think I've seen the map before, which is very compelling to me, and that map and obviously the sort of fixed effects that you control for. I still would be, curious just to see sort of a breakdown of the population characteristics of people in the high and low mortality areas. I know you had very little time. It probably could be in another presentation, but just, further a little bit more empirical demonstration that those populations were comparable either on sort of fixed characteristics or any data you have pre-tsunami. But again, it's a very, as has been demonstrated over the years, a very interesting example that I'm glad you're continuing to use to understand things. The final comment that I really have is just about T3 itself, and with your clinical background, probably definitely know more than me about this. But my understanding is that high levels are bad and low levels can be bad, and so it sort of has this distribution that you don't want it too high or don't want it too low. A little bit like BMI. So I'm wondering how much you might want to explore either some categorical classifications of T3, people who are sort of at the sweet spot, not too high or not too low. Maybe this isn't a factor in Indonesia, but, or something like quantile regression to look at, effects at different levels of T3. But again, just a fantastic paper. Great to see this work. And, hopefully other studies will start looking at T3 more, and there'll just be more and more factors like this that we can start interrogating to get a bigger picture of how stress is functioning. And really, this work being just so orthogonal to a lot of the other stress literature with this nice intervention and nice sort of quasi-experimental paradigm that you have. So again, great to see this work. Finally, no problem about the presentation. It was great to see the paper from Tura now, and fantastic to learn about the LC data. It was a really nice framing of the question, very clear presentation. So the things that first came to mind to me is how interesting and how important the sort of cross-national comparisons in regional variation within place are. And so, I'm always, I spend a lot of talks and motivate a lot of my talks by these just extreme regional differences in health in the U.S., whether you look at county or state, that, within the U.S. we have counties that are some of the highest would be, the highest life expectancy country in the world, or would have a life expectancy of, around 125 in the ranking. And so studying these within country regional differences are really interesting. But I think, what this brings up for me is the potential to look at how these regional differences vary by country, and how much, some of these compositional effects that you saw with education and region, which I think is a really interesting intersection to look at, may or may not play out in other places. But certainly those compositional effects that you discovered here were really stunning, really, really interesting work. So one of the methodological questions that brings up for me when I think about that type of work is how we think about regions in different countries and how we might think about that in comparison. So the units, may matter really differently in different places. Obviously, the political units differ by size, and the sort of social importance of different regions differ. And so I think there's potentially interesting work to be done in a comparative sense to think about how we make some of those comparisons, how we think about what you've demonstrated in Brazil might be going on in other countries. And really think about these different levels, and how by exploring composition at different levels, it might lead us to think about what the units are like in different countries, how those units might lead to health differentials in aging, and how that itself might differ by country. So again, fantastic to see this work, and look forward to seeing more work coming out of ELSI. And thank you all again.
Thank you, David. Thank you for your comments. I appreciate it. So I think in the interest of time, we have about 20 more minutes before the next session. I think I would like to open it up for questions, and then once we get a few questions, you guys can reply to David's comments and the questions that you might receive. So if anyone has any questions, those who are online, you can. I believe you can unmute yourself if you want to raise any questions. Eileen?
Thank you. I'll go first because it's always slow getting started. Those were great papers, and a really great discussion by David. Thank you all very much. I wanted to address my first question to Hanka. So, the projections you have are absolutely shocking that 66% of these population will have hypertension and 33 will have diabetes. I feel like if you're going to now model cognitive loss, you may need to think about these things not only individually but also jointly because there's a lot of work on the risk factors for diabetes that sort of indicates there's an interaction between the cardiovascular and the metabolic system. And I don't know how your projections could get much worse, but I do think they might because of these extraordinarily high levels and then starting at a very young age, as David indicated. So the outlook for dementia might be really quite shocking. And so I think my recommendation is maybe think about some sort of interactive type model that's a little bit different from the traditional FEM model that you've used. Thanks.
Yeah, for sure. Yeah, we can yeah, the rates are high. It's increasing. They're high in the US too, in that sense. We can definitely do interactions between hypertension and diabetes and other factors. And I think that would be important if from a theoretical perspective, how we think about those correlations. What I would like to say in terms of how that would affect cognition is that there's a lot of competing risk. And if more people have diabetes and hypertension, people don't live as long as they normally would, and that would decrease risk of dementia as well. And so it is a complex dance of risk factors, but I think we can model that well for sure. Going into the question of how if we can do younger ages and how that would that we would definitely require younger ages in the data set, and so that would be I don't know if there are good longitudinal data sets for younger ages for Mexico. I don't believe so. So in US we do we have the FAM, the future adult model, or future American model, I should say. And that is based on the panel study of income dynamics where we use younger ages, and we don't have that resource for Mexico just yet. So, but it would be fantastic if we do, and I think it would be important to see how that if you know the earlier years are very important for the later years, and I think it's fantastic that the MHAS has been so great the last couple of years. It's been very regular, and I hope that it continues, but I hope that it also would develop into younger ages.
Thank you. And any other questions? Anyone else? Duncan?
So I also have a question for Hanki. I thought that the presentations were excellent, and discussion, David, was brilliant. The two questions I have are related much more to how you think about modeling and the interaction with measurement. The first is that the bad health outcomes or absorbing states. How do you think about medication? Because certainly the very high rates of hypertension are things that could be controlled. And what is your measure of diabetes? I thought MHAS, initially at least, only asked whether people have been diagnosed with diabetes. Is that true?
Yes, we use the questions based on have you ever been diagnosed by a medical by a physician. And so yes, it is self-report. It is diagnosed when people are not aware of this, of their disease status, they will not answer it. So in that sense, it is based, or it's dependent on how good those measures are. And of course, they can be very flawed in countries where diagnostics are not as good. And so if you think about more access to healthcare, you could see increases in prevalence of certain chronic conditions, but then but if they are then being treated, that would be a better situation rather than a worse situation. So yeah, it is based on diagnostics. That is as good as we can get it for MHAS.
I think actually there are other data sets which have measured diabetes. They have HbA1c, and I certainly think that there may even be some from that National Health Institute that actually ask whether you think you have diabetes and then actually measure. So you could actually do some crosswalks. And I don't think it worked out terribly well for the self-reports, because you can imagine the self-reports are much more likely among higher income people who have much better access to healthcare. So you're sort of systematically understating the incidence of diabetes among the poorest, who may also be the least educated. And apropos what Eileen was saying, most at risk of having cognitive problems earlier in life.
Yeah, but in 2012, now that you mentioned that, Duncan, in 2012, there is a biomarker section. That was the year in which M has actually collected biomarkers. And if I'm not mistaken, HbA1c is included in it.
So it seems like it's really worth putting those data into the model and thinking about how that's related to the questions of have you been diagnosed with diabetes?
Yes, that would be very, very nice addition. I think those are a single point in time, if I'm correct.
But at least you would have that crosswalk at one point and then maybe do some projections. The crosswalk, you can do some other projections as well, because maybe healthcare has changed using the INSP data, I think.
Yeah, and then
or even MXFLS, I think, has diabetes.
Yeah,
Right.
no, that's a good idea, and yeah, that's a good idea. Thanks.
And Will Dow just included also there is an additional data set in Mexico that has cross-sectional data in 2012. There is a much larger sample. It's the equivalent of the NHANES in the US, but for Mexico. And it has a very large, the NSANUT, has a very large sample of biomarkers.
Yeah, that's great. Yes.
Excellent. Thank you, Duncan. And any other questions?
We'll put one in the chat for Ralph.
Oh yeah, there are some for you, Ralph.
Yeah, Ralph, I'd love to hear a little bit more about the measurement and limitations, or just some more about measuring T3.
Yeah, I guess just to start off here, David, thank you for the great discussion. I think we're talking to Duncan about this, that I really have no sense that people are into thyroid function besides me. So it's great to get some feedback that is interesting to at all a broader audience. So really, really appreciate it. In terms of measurement, I need to look up, I can get the numbers for how much it cost us. It was not super cheap. I don't think it was anything totally crazy. It's a venous blood draw. The main thing I think you'd want to just be aware of is that we're kind of early days for understanding the downstream thyroid markers. I don't think we have clear clinical cutoffs for either end of them yet, right? We have a lot of evidence that the variation correlates with the things we think thyroid should be doing, right? But it's not totally obvious that we have a clear disease state cutoff if you wanted to be going that direction, right? So I think it's interesting in terms of how do you think about subclinical changes in metabolism that could be really important. It's hard to say anything about disease specifically at the moment. That's probably the primary limitation we're thinking about. There's also historically a lot of why I think people focus on TSH for thyroid measurement is because until recently, it was actually very hard to measure thyroid hormone, to measure T3 reliably. So clinicians are very uncomfortable with having a measure that wasn't super clear with the cutoffs. I think it's changed recently, but I think that technology is improving here pretty rapidly. So, hope that is useful. I get you the numbers on how much it cost us too.
Ralph, how many TSH, FT3, and FT4 measures do we have in the sample? It's about 6,000.
In this sample?
Yeah.
We had about 3,000 T3 measures. And then we did a couple hundred T4 and TSH.
All right. So these are really expensive.
Yeah.
So those cost us 80K.
Oh, okay.
But that was because we thought that it was really, there is a link between exposure to stress and thyroid. And we thought we should try and do this on a very, very small subsample. And that's why, and the number we did was a function of the cost because they're so expensive. And that's the problem with all these biomarkers for us. They are expensive.
Yeah. Thank you. Any other questions?
Yeah, thank you, Ralph. And if I can just go back to Casio. This is fascinating work. Thank you. It's so valuable to be able to look really carefully at these issues and especially the misreporting. I was I just wanted to follow up. Thank you for the linkages on both age and education misreporting. So for the education misreporting, you weren't pushing that as a main story. I just wanted to make sure that I'm understanding this in the right way. Where you were seeing I think the most unexpected results for education was that middle education group, where the mortality rates seemed to be unexpectedly low in the north. And I would have thought that would have been driven in the other direction if education misreporting was important, because you'd get some people moving from the low education group misclassified into the medium education group. How are you thinking about this? Oh, you're on mute.
I think we cannot hear you, Casio.
Thank you so much, Will.
Oh, there you go.
Thank you. And thank you, David, also for the questions and for following my presentation. Excellent questions. So regarding the education misreporting, it may be operating more in the southeast than the north. That would be my explanation, because the education expanded faster in the southeast than in the north, maybe. And that's why people are inflating, because they look at the younger cohorts. Everything here is our hypothesis. We were not able to test. People can also make mistakes in terms of when reporting the education because of the various changes that the system experienced over the history. So it's not that easy to collect education data in Brazil. So it can be one explanation. But regarding David's question on the geographic boundaries, and there's something very interesting, David, in Brazil. So your question is really relevant. Is the fact that the north and northeast are very different from the south in Brazil. So if we compare the southern state in Brazil, Rio Grande do Sul, close to Uruguay, to Argentina, it's a state that was colonized by Europeans, Germans, Italians. And if you compare with Roraima, Roraima is close to Venezuela. It's far, far away. Brazil is huge, and it's very different. Okay, so if we have the life course hypothesis in mind, infant mortality rates used to be much higher in the north than in the south. So if these things leave some scars, we should see, and I think scars are more important than selectivity. In the case of Brazil, you should have seen difference between the older guys in the north and the older guys in the south. However, there's something special in Brazil. Social security is universal. Social security, income transfers. Brazil is an example of the social security expansion and coverage in whole Latin America. Now we are facing terrible problems with population aging. But it's 95% of people get something, first. Second, health. The public health system is universal and free. And the territorial coverage has been increasing a lot in the last 2 decades. So it may be, so that's something very interesting to look at, that income transfers plus public health system may be compensating for the scars, mitigating the scars, right? I don't know. And then everything gets a little bit the same at older age in terms of health and mortality. I don't know. But everyone can go to a doctor, to a hospital, get medicines for free, at least for the most common, no, for every disease, but for the most common, like diabetes, hypertension, people get free drugs. I don't know. I don't know the impact of this in terms of changing the life course scars. But your question is very important.
Thank you, Cassie. Thank you. So I think we have 5 more minutes. So I just want to see if anybody else has any other questions. If not, I can jump and ask perhaps the last one. Nobody else? Any takers? So then going back, Casio, to your paper, again, also found it very interesting. So I wonder if in these type of populations, which are somewhat similar, like in Mexico, education is actually the marker that one wants to use to look at this mortality differential, just because education is so low in many of these cohorts. There is only so much variability on the one hand that you would have, and on the other, the mortality rates for the North region would be so jumpy and so uncertain for middle and high levels of education, just because you don't have that many people in those groups. So what I wonder is whether actually net worth or an indicator of, you cannot use income because many of these individuals probably never have worked, particularly in the Northeast or in the northern region, in which there is not so much, it's a lot of employment that is self-employed, and they are not in the formal sector. So I wonder if an indicator of net worth might allow you to disentangle a little bit of those mortality differentials, because then you could actually increase that mortality variation that you could have, in contrast to education that is fairly, as you indicated, in the Northeast, almost half of the population has no education, and the fraction with some sort of education is very small.
Totally agree. Totally agree. And in Brazil, for the older cohorts, it's middle level education, which is the social vaccine, let's call. It's changing because younger cohorts are getting more education, but you're totally right. So it's the second, it's high school. If you have complete high school, you do much better than people without high school. And tertiary education is pretty less prevalent among the elderly, so it's much harder to get. So you're totally right. And for income also is difficult. So you're right with working with wealth, because of the public transfers in Brazil. So public transfers in Brazil tends to normalize the income of the elderly also. Thank you. You're right.
Thank you, Cassio, and thank you everyone for very, very interesting presentations. So any last minute questions, comments before we move on to the next session? Nobody? Great. Well, thank you everyone. Really appreciate it. Thank you, Hanke. Thank you, Ralph. Thank you, Cassio and David, for fantastic. So yeah, thank you everyone. So then we'll probably move into section number 2 on environment, sex, and aging.
Why don't we get ready to come back together? So I think that our discussant, I hope that she'll be joining us momentarily. We sort of reached out to her to make sure. But why don't we go ahead and get started, since we do have 4 authors here for this next session, so we'll have only a few minutes less for each presentation. So without further ado, the first presentation on our schedule is by Zubaria and Lib. So Zubaria, do you want to unmute and share your screen? So moving right on to Elijah Watson at Northwestern University. We can see your slides, so you're good to go.
Great. Excited to be here. Thank you for having me. I'm presenting here work for my dissertation. I'm a PhD candidate in biological anthropology. I'd like to acknowledge my co-authors and also NIH funding for my F31 and my advisor, Chris Kuzawa's R01, which funded the biological aging measure collection that I'll be talking about some today. So the question that I'm addressing in this talk, does prenatal exposure to a political economic crisis shape biological aging across the life course? There's been a lot of work in the fetal origins of health and disease, primarily looking at outcomes like obesity or cardiovascular disease or mortality. But recently, with the advent of epigenetic clocks and these methylation measures of biological aging, we started to see evidence from canonical studies like the Dutch hunger winter, also recent work looking at the Great Depression, showing that higher levels of prenatal stress from these plausibly exogenous shocks increases epigenetic age acceleration in adulthood. However, most of this evidence comes from high-income context. Often these shocks that are studied are kind of relatively short-term in the broad scale of the life course. The Dutch hunger winter was certainly tragic, but the Netherlands kind of returned back to a state of maybe normalcy. So generalizability to more prolonged crises or just fetal origins effects in lower income settings is still somewhat unclear. The data I'm going to be talking about today comes from the Cebu Longitudinal Health and Nutrition Survey. I don't have time to really get into the details of the study, but what's important to know is that about 3,300 pregnant women were enrolled in metropolitan Cebu, which is in the province of Cebu in the Philippines, includes greater than people just in the city of Cebu, also some surrounding cities. But from 33 neighborhoods, pregnant women were randomly sampled and they were enrolled in them, and their offspring were followed through to 2023 was the most recent survey wave when they were age 40. Today, I'm going to be talking about data from the pregnancy and birth surveys, the infancy surveys, which were bi-monthly up to age 2, as well as biological aging measures from 2005 when they were 21 and 2023 when they were age 40. So, what's not yet been examined with the Cebu Longitudinal Health and Nutrition Survey, a lot of work has been done looking at health over the life course and development over the life course. But something that's not yet been examined is the fact that whenever the study began enrolling in May 1983, the Philippines was just about to enter a period of extreme volatility. Most saliently, I'm going to first talk about shock 2 here on the right. At the time, the Philippines was under the rule of Ferdinand Marcos, widely characterized as a dictatorship, and Benigno Ninoy Aquino was kind of the lead opposition figure against the Marcos regime. He'd been exiled to the United States, but decided in August 1983 to return to the Philippines to try to run against Marcos in a hopefully democratic election process. But upon exiting his plane in the Philippines, he was shot and assassinated and died on the spot. This sparked acute national political crisis, capital flight, the peso devalued 50% over a relatively short time. And this is really the central shock that we were coming into this study to study. However, just about a few months before in June, there were some other things going on that will become more clear in a moment why it's useful to study it as well. And 2 months before, there was a 7% peso devaluation in the end of June, really setting up the country to be in an economically fragile place. And also, there was really severe flooding in Cebu. There was a typhoon that didn't hit Cebu directly, but tropical storm flooding from the typhoon really hit the city hard. There was international news coverage of a footbridge collapse that connect two high density areas where people would travel for work, and over 100 individuals died in that bridge collapse. So we're examining these two as relatively uh, mild and then more severe exposure to prenatal stress. So the timing of these two shocks. So what we're looking at here is birth weight. On the left, we have the group exposed to both the June and assassination shocks, and on the right, just the June shocks. You can see the effects are similar across both groups relative to those born before both the shocks. They were born about 50 grams lighter. I'm not showing the results today for the sake of time on birth length or low birth weight, but we see a similar magnitude decrease in birth length and about a 4% reduction in low birth weight across both of these groups as well. So this gives some credence to the idea that this was a prenatal shock. We're seeing kind of the expected birth weight drop. Here, I'm not going to spend too much time on this for the sake of time, but we did a robustness check looking at the number of hot days during pregnancy, and it didn't change the effects too much. That was one of our main sort of co-occurring exposures we're worried about is seasonality. Now, so we see this decrease in birth weight, but importantly, this wasn't just like a blip. Like the assassination wasn't just a psychosocial stressor. It sparked, a period of economic decline that really lasted 2 years, and beyond that. I say 2 years because, as I mentioned before, Aquino was assassinated. 2 years later, there was eventually a peaceful transfer of power through the People Power Revolution, and his spouse, Corazon Aquino, was elected president in 1986. But during that 2 year period, which overlaps really nicely with the first 2 years of life, an important sensitive period for growth and development, we can look in at the data. Here, looking at a population level in the Cebu data, these figures are reflecting 2 month steps in calendar time, the changes in each of these indicators, whether they answered yes to using the breastfeeding or formula in the past week, net of infant age. So what we see is that breastfeeding rose about 1% every 2 months, while formula use decreased. But more worrisomely, we see that the introduction of sweetened liquids, solids, and water also increased over time, again, independent of infant age. So kind of gives us a characterization that the postnatal context was worsening with respect to infant nutrition. We also can see in household income data that there was a big drop, especially for the wealthiest households. This is looking over a decade. So at the end of that 2-year period, we see kind of a reversal. This might seem surprising at first, but what we see here is a rebound. This is looking at BMI Z-scores. We see that they're about 0.3 standard deviations larger than those that were unexposed, similar across both groups. So we're seeing a bit of perhaps a rebound effect. But I think more importantly, if we look at the other end of the BMI distribution here, looking at the risk of wasting, we see that both exposed groups actually have about a 4% lower risk of wasting than those that were born before the shocks. And this leads us to think that we might be seeing some buffering, that the infants that were exposed to those prenatal stressors might have been a bit more prepared to enter a harsh postnatal world than those who didn't have perhaps well-matched prenatal signals. Now I'm going to look in at the epigenetic aging results at age 21 and 40. For the sake of time, what we need to know is that if your epigenetic age is higher than expected for your chronological age, it suggests accelerated aging. I can answer more questions if anyone wants to know details about these measures in the Q&A. So what we see here, again, on the left is the people exposed to the assassination and the June shocks on the right, just the June shocks. We see that there's a statistically insignificant effect, but suggesting higher accelerated aging perhaps for those exposed to the assassination. But more interestingly, in line with what we saw for the low risk of wasting and the higher BMI, for the June-only group, which had maybe a relatively milder shock than the June and August group, we see a significant decrease in the pace of epigenetic aging here. So what we're looking at, about 0.2 standard deviations lower. And although, and that was age 21. And so now at age 40, we see, again, focusing in on the right, we see that for the June-only group, that decline persists, and the point estimate stays about the same, about 0.25 standard deviations lower. On the assassination group, we see now the point estimate sign is flipped, but still uncertain. And to wrap up, though, I want to we've seen that there might be some evidence of buffering here, but what if we just look within the exposed, comparing those exposed to the assassination to those born just before, just to the June shock? What we see here is maybe what we would expect. There's higher epigenetic age acceleration at age 21, measured by Dunedin pace, the pace of epigenetic aging. And this seems to decrease some by age 40, but the point estimate is still there. So higher levels of stress still are worse for the body. And here we're looking at in a different epigenetic clock, not the pace of aging, but the level of epigenetic aging. We can see that at age 40, the level effect actually persists. Even though the pace might be going down, we're still seeing that the level persists. I know I'm about out of time, so the last thing I'll say is that we're now looking into infant feeding. Like I said, the infant feeding context got worse, but it actually appears that across groups, infant feeding doesn't appear to be driving these results, but those are all in progress. Thank you.
Well, this is fantastic, and I wish we had a lot more time for you, but thank you for staying in the time that we did have. So let's keep on going to the next presentation then. Anwar Hossain from the Max Planck Institute and the University of St. Andrews.
Hi, I hope you can see the screen now.
Yes, we can see it. Thank you.
All right. So, good evening, everyone. I'm Anwar, a second-year PhD student at the Max Planck Institute for Demographic Research and the University of St. Andrews. I'm going to present the first chapter of my dissertation, Inequality's Toll on the Ovarian Clock, Socio-Demographic Gradients in Early Menopause Across South and Southeast Asia. So the study was motivated from the fact that the timing of menopause, although age is one of the core demographic variables, has received very limited attention from demographic perspective. So let me start with a simple point that menopause is not just a clinical milestone, rather it is a demographic parameter. This is because the timing of menopause marks the end of reproductive exposure. It shapes cohort fertility schedules and determines how long women live in post-reproductive state. The timing of menopause is also a key determinant of major non-communicable disease and mortality. For example, when menopause occurs before age 45, it substantially increases the long-term risk of cardiovascular disease, osteoporosis, and premature mortality. So what else do we know from the literature? From high-income countries, menopause typically occurs among women between ages 50 and 55 years, and there is a clear social gradient. That is, socioeconomic disadvantage is associated with earlier menopause transition. Importantly, parity or having children in those settings is usually protective. It is likely because ovulation is suppressed during pregnancy. So that is kind of the benchmark in the literature. But this benchmark is based almost entirely on prospective cohorts from high income and low fertility settings. Life courses in low and middle income countries, on the other hand, look very different. For example, women in low and middle income countries have earlier first marriages. They also have higher fertility, often under nutritional stress and under fragmented healthcare systems, with limited access to conservative gynecological management. So in such context, menopausal timing may reflect not only natural ovarian aging, but also non-natural or iatrogenic pathways, such as the high rates of hysterectomy. For example, in India, hysterectomy scam was a major public health concern where women from a disadvantaged socioeconomic profiles were targeted to undergo hysterectomies due to insurance incentives. So the mechanism of reproductive aging, we argue, in low and middle income countries may not be the same as we see in high income countries. So we focus on South and Southeast Asia as a starting point for three specific reasons. First one is the scale. This region contains the largest number of midlife women globally and is aging rapidly. Second, its heterogeneity. South Asia and Southeast Asia differs sharply in the fertility regimes, education levels, and health system capacity. This makes the region a natural setting to test whether the socio-demographic gradients are universal or context-dependent. And third, the burden. The prevalence of premature and early menopause in this region appears higher than in high-income countries. However, most existing estimates in South and Southeast Asia rely on demographic and health survey data using inconsistent and often undocumented reconstruction method. And this is important because age at menopause in DHS is not a readily available variable. So our study contributes a robust methodological blueprint to utilize the DHS data in studying timing of menopause in low and middle income countries, which I will elaborate further shortly. So in particular, this study focused on three research questions. First, how has the average age at menopause changed over time in these regions? Second, what were the country-wise prevalence estimates of premature and early menopause in South and Southeast Asia between 1991 and 2022? And third, how were education, parity, household wealth, and place of residence associated with early menopause? And did these associations vary between South and Southeast Asia? To answer these questions, we utilized 51 demographic and health survey data from 12 South and Southeast Asian countries, covering data from 1991 to 2022. All these surveys included a key question: when did your last menstrual period start? We then followed World Health Organization's guideline for menopausal classification. So now let me elaborate a key methodological issue that we had to resolve. So in DHS, menopause is tracked using variable V2 to 6, which is a complex variable with both numeric and non-numeric responses, as you can see in the sample questionnaire from Bangladesh. However, every survey, a large share of women, on average 7% to as high as nearly 20%, were coded as before last birth, meaning these women had their final menstrual period before their last pregnancy, and they did not continue, their period did not continue afterwards. So prior studies simply dropped them as the mostly included numeric responses only. The problem is that excludes real postmenopausal women as well as those with temporary postpartum amenorrhea. So we handled this issue differently and developed a robust imputation technique based on two approaches. This is one of the major methodological contributions of this paper that I mentioned earlier. For the sake of time, I will not go into the details, but this approach recovered almost 31,000 postmenopausal cases that would otherwise be lost, and it mattered. Our estimate of early menopause rose from 3.8% to 6.6%, and early menopause from 7.3% to 7.5%. We then approached the data analysis in two parts. First, we conducted descriptive analysis to map the broad trends. We calculated singulate mean age at menopause using John Hasnell's method for singulate mean age at marriage, and used linear regression to trace its evolution over time. And then we estimated country-specific prevalence rates for premature and early menopause. For the multivariable analysis, we narrowed our focus to 11 most recent surveys from 2015 to 2022, encompassing a sample of nearly 500,000 women, ever married women aged 30 to 49. We fitted a population averaged Cox proportional hazard model with robust standard errors clustered by country, incorporating interactions between socio-demographic variables and region. To ensure the robustness of our results, we tested the proportional hazard assumption using Schoenfeld residuals and supplemented our primary model with extensive sensitivity analysis, including piecewise Cox model to address the population hazard violation, and shared frailty models that accounted for unobserved heterogeneity. Plus, we examined potential recall bias in the data, as well as testing the main results with alternative sample and outcome specifications. So let's start with how the average age at menopause has changed. So in most South and Southeast Asian countries, the age at menopause has been gradually increasing. So women are reaching menopause a bit later than before. But that's not the case everywhere. In Cambodia and Pakistan, for example, things have stayed flat or even declined a bit. This is also confirmed when we see the trends in singulate mean age at menopause and their annual change. So simply put, average age at menopause is increasing in South and Southeast Asia with a varied pace across countries and regions. Now, looking at the prevalence rates, premature menopause has decreased slightly in most countries since the 1990s, which corresponds to our earlier findings. But early menopause prevalence has gone up in most countries. So even though fewer women are going through menopause transition before 40, more are transitioning in their early 40s. Here's what we found from the Cox model. Women with no education had around 82% higher risk of early menopause compared to those with higher education. When it comes to number of children, having one child increased the risk by 27%, and having two or more children by another 17%. Now, this is a novel finding, as existing literature from high-income countries show that nulliparity or childlessness poses higher risk of early menopause. We also find a clear wealth gradient. That is, women in low wealth group had a 38% higher risk compared to high wealth group. Now, what's interesting is the regional difference. Overall, women in Southeast Asia had a 41% lower risk compared to South Asia. But within Southeast Asia, the effect of disadvantage were much stronger. For example, women with two or more children had more than double the risk of early menopause compared to similar women in South Asia. And the impact of low education, rural residence, and high parity was also more pronounced in that region. So as there were widespread violation of population hazard assumption in the main Cox model, we ran a set of sensitivity analysis to check if our main findings held up, and they did. To save time, I will not go into the details, but overall, the consistency across models gives us the confidence that the patterns we found, particularly around education, parity, and regional difference, are robust. So what did we uncover so far? First, we provide a robust characterization of menopausal timing in South and Southeast Asia, revealing that average age at menopause generally increased over time in most South and Southeast Asian countries. Second, the share of women experiencing premature menopause has slightly gone down since the late 90s, but early menopause has gone up in several countries. Importantly, we reveal that the prevalence of early menopause in South and Southeast Asia is 7.5%, a burden that is 67% higher than previously understood. Third, when we look at the risk factors, things get more interesting. In South and Southeast Asia, women with more children tend to reach menopause earlier, which is reverse of what we see in high-income settings. We also saw a strong socioeconomic gradients in the risk of early menopause. Importantly, women in Southeast Asia overall had a lower baseline hazard of early menopause. But the adverse effects of low education, high parity, and rural residence were more pronounced there compared to South Asia. So, what are the key takeaways from this study? First, the menopausal timing in South and Southeast Asia is clearly socially patterned. That is, socio-demographic disadvantage is associated with earlier menopause transition. Second, the mechanism may differ from what we see in high-income countries. In particular, higher parity appears to be linked with earlier menopause in South and Southeast Asia. So these findings indicate that inequality's toll on the ovarian clock is significant. Third, the measurement matters. When we address menopause variable reconstruction issues in the DHS, the estimated burden of early menopause increases substantially. Taken together, these findings suggest that reproductive aging should be studied as a population health indicator shaped by life course inequalities and the health system context in which women live, particularly in low and middle income countries. That is all from my side. Thank you very much for listening. I will be happy to take any questions you may have.
Thank you so much, Anwar. That was terrific, and thank you for staying right in time. And I'll just remind everyone that I think that when you registered, you have also will be getting access to the slides that have a lot of details that people had to go through fairly quickly. So I know you had to move through these, Anwar. So let's go to our last presentation this session, and then we'll move on to our discussants and open up for questions after that for all four papers. So Margarita Osuna from USC, we can see your slides, so please take it away.
I had to unmute myself. Thank you. Well, thank you, everyone. Thank you for the presenters. This has been really interesting. My name is Margarita Osuna. I'm a postdoc at USC, and I'm here to show some preliminary findings I have on early menopause and later life health among women in Brazil, Colombia, and Mexico. So I'm so glad that the previous presenter came before me because he did such an incredible job explaining menopause and what it is. And I think just to sort of sum it up, we need to keep in mind that menopause is the point in a woman's life when menstruation stops permanently. It is usually defined as 12 consecutive months without a menstrual period. And menopause is for women one of the most important health transitions in their life. It often carries a symptom burden, and it also carries different health factors and health risks. And so we know from studies in high-income countries that early menopause, particularly, which is usually at age 44 or younger, is associated with accelerated aging, increasing morbidity and mortality, and it is accompanied for women by increased risk of cardiovascular disease and stroke. And also studies have shown that it has accelerated bone loss that increases the risk of osteoporosis and fractures. Menopause also involves hormonal changes for women, which may cause shifts in behavior and psychological stressors. And in Latin America, particularly, lots of studies have been looking at this and seeing how age of menopause or menopause symptoms affect social factors such as affection with socializing, increasing depression, and increasing anxiety. But as our previous presenter pointed out recently, a lot of the studies and what we know that has been conducted in high-income countries on menopause may be different in other low to middle income countries because we know that health disparities and differences exist in these countries. So in Latin America specifically, we know that the published literature on menopause is small. There has not been a lot of publications. Most of it has been done in cities with very small samples or in clinical samples. And because of this, there's a lot of variation and heterogeneity in what we know. And so, for example, the mean age of menopause, there's a wide variation from what the studies have shown. Studies focusing on menopausal symptoms vary depending on what they're looking at, what country they're studying, and what samples they have access to. And so, to date, we were able to find only one nationally representative study that was looking at menopausing timing and health in the region, which was conducted in Brazil. But fortunately, we now have studies that have been thought as or have been conducted thinking of older adults and older adults' health in Latin America that ask women about menopause. So these are the Mexican Health and Aging Studies, MHAS, the Brazilian Longitudinal Study of Aging, LC, and here I'm also using data from the Colombian Study of Aging, COSA, the pilot. For MHAS and from Brazil, we know that they're nationally representative of older adults and they ask women about health and menopause. And COSA, many people might not know this study. It is not nationally representative. It is a pilot, but it was designed as a foundation for a future nationally representative aging study. And it also contains details information that inform on later life health and menopause. So the research aims, similar to what the previous presenter presented, is to just show what the average age of menopause is for these countries for women, estimate the prevalence of early menopause, and also investigate if early menopause is associated with later life health outcomes among women in Latin America. I already spoke a little bit of these studies, so I don't think there's a need for me to go deep into them, but I just wanted to point out, I know there's lots of you here in the meeting that use these data, that I'm using years 2015 for MHAS and for LC. The COSA study pilot came out in 2025, and then these are the analytical samples I have. And just as a reminder, COSA is not nationally representative. That's why it's a smaller sample size. And all of these surveys collected data on sociodemographic characteristic, women's health, health, and activities of daily living. And it's nice to use these surveys because they were all based, or they're all HRS sister studies, so they're very comparable. And you can see you can see the same questions asked in the three studies, so it's easy to harmonize. What we have for sociodemographic characteristics, I was looking at the age the participant was when they were interviewed, their marital status, urban rural status, and education. For women's health, the questions were either when did you start your menopause, or until when did you have your last period? So we took those ages into consideration. These studies also asked about women's preventative care, like last time there was a cytology or a mammogram exam. And then some health questions that we are taking into consideration in our analysis are diabetes, cancer, hypertension, stroke, heart attack, arthritis, and lung problems. And I'm also looking at disability in activities of daily living, which are toileting, bathing, dressing, getting in and out of bed, and eating, and walking across a room. So I am going to sort of skip this slide. This was just a reminder of what I'm doing. I'm going to talk about the sample characteristics first. I know this is a pretty big table and there's a lot going on, but I think it's important to just highlight a few things before we go through it. Here I have each study. I hope you can see my cursor. We have COSA, LC, and MHAS, and then I have for each study a separation of the two samples, whether the person was early menopause onset or normal or late onset. And I'm sort of presenting to you the sample characteristics between these two groups for each study. So for the mean age, what we can see here is that the studies were very similar. The mean age was 64 to 66 years. For education categories, most of the women had some primary and some secondary too. Education. For reproductive health history, For reproductive health, I would just want to point out here something that I find interesting and that is important when you investigate menopause, and it is hysterectomy. So what we see is that for all the studies, women who had early menopause and onset had a higher proportion of women said that they had had a hysterectomy. And this is the case for Colombia, this is the case for Brazil, and this is the case for Mexico. And then lastly, I just want to point out here that for health, we had two very prevalent diseases, which were hypertension and diabetes. Okay, so this is the average age of menopause among women in Brazil, Mexico, and Colombia. We find that the years are similar across the studies, but if you compare it to what we know from other studies in Latin America or in China, we can say we're, close or near that same age of menopause. It is a much lower age than in the US, and it is a bit higher than in India, although a lot of research has been done pointing to the fact that India does have a low or a lower menopause, average age of menopause. We also looked at prevalence of early menopause, and what we found is that the prevalence of early menopause is very high in Mexico. Then is the second highest was LC and followed by COSA. And when we looked at some of the literature, we found that it was similar to India and Korea. So MHAS and LC were similar to India and Korea, and all of the studies were much higher than what we know from China, Korea, and the US. Sorry, I meant to say MHAS from Mexico and Brazil, LC. We also ran some logistic regressions. So here I'm presenting the odds ratios for early menopause, predicting later life health outcomes, and I'm going to show them to you for each survey individually. So what I have here is for COSA, what we found is that what we found is that having early menopause was associated with higher risk of hypertension, diabetes, stroke, arthritis, and ADL disability. Before I continue, I think it's important to mention that all of these models are adjusted for age, education, and urban and rural status. And here's where it gets a little bit interesting, and I would love some of your thoughts on this. But when we looked at the same regression for Brazil, we didn't find any significant associations. And then for Mexico, we found that having early menopause was associated with a higher risk of heart attack among women in Mexico. So sort of some of the conclusions and some of the thoughts we have here. Well, what we can say to start is that the average age of menopause was similar across the three countries. Early menopause was more prevalent in Mexico, but all the Brazil and Colombia had similar countries than those like India or China, but lower or higher, sorry, than in the United States. Although findings across studies are mixed, we can say that early menopause was associated with cardiovascular disease in Colombia and in Mexico, and we definitely need more research to better understand women's health in these rapidly aging populations, and that are unique and are different from high-income countries and from what studies have shown there. Now, we are currently working on some future work examining health behaviors. We know smoking in other studies has been associated with earlier menopause, and so is BMI. And we're also looking at reproductive histories such as age of first menstruation, number of children, and other things. Thank you so much. Made it right under time.
Yeah, fantastic. Thank you so much, Margarita. That is fascinating work, and thank you for getting right under time. I know these are such rich studies. I wish we had more time for everyone. But why don't we move to Jennifer's comments right now? So Jennifer, you have 10-ish minutes. We have a couple extra minutes as well. We're slightly ahead of schedule, so we'll hopefully have lots of time for Q&A. So Jennifer, thank you.
Thanks, Will. So this session was, I believe, organized especially to my interests, or at least that's what it seems like. I understand it seems like there's a set of presentations on environment and a set of presentations on reproductive aging, but I actually think that the common thread running through these presentations is our need to take research that's maybe become a bit stale or is now outdated, and to try to really find ways to update this so that we have a better understanding of some of the issues that were discussed in the session in broader context. So I'm just going to provide comments in the order of the presentations, starting with the first presentation on heat, which I thought was a really nice use of data and methods to examine what's now an increasingly important issue for population health and aging. And this was a study in Pakistan, but I could imagine the study being carried out in any number of countries. And we certainly know that those are the kinds of patterns that we've seen for hospitalizations and acute health events in countries like the United States and the United Kingdom. What I think was really novel about the approach that was taken in this study is the focus on some of the subgroup differences, which they were able to do with, such a large data set. But the fact that the larger effects were found in these less resourced areas, I think on the one hand helps us to understand where the underlying vulnerabilities are in the population. But although we're all mostly demographers and we don't work in kind of policy and implementation, that kind of an analysis, I think, is really helpful for us to understand what are the potential strategies that we could employ to reduce heat impacts on the population. And so in this case, I think it's pretty obvious that the low-resourced areas don't have good mechanisms to cope with heat, and so the populations will be more likely to suffer adverse health outcomes. The challenge I think that we're going to have is that climate adaptation in some contexts is going to be very difficult. So we know this is going to have a massive population health impact. We know that climate adaptation could be the potential intervention point. But we also know that this climate adaptation has to happen in contexts that are lower resource settings in general. So these are lower and middle income countries. And so I think that just means that we need more innovation. The good news is what we've seen historically is that low and middle income countries that have, more rapid population aging or have to respond to environmental challenges more rapidly than higher income countries with fewer resources do tend to innovate better. So they're relying more on innovative ways to cool and heat locations. The only question I had for the presenter was there was the finding of the age pattern differences in mortality. It was much higher among the 45 to 65-year-old group than the 65 and older group. And we would think from an aging biology perspective that the oldest people would probably have the worst health impacts. So I'm curious if the author thinks it's more of like a mortality selection issue, or if the 45 to 65-year-olds are the ones who are kind of out in the heat working, and maybe older adults have some protection because they can stay inside or in the shade and stay away from the heat a little bit. Okay, and then moving on to Elijah Watson's paper on prenatal stress and midlife biological aging. I thought this paper was a really nice extension of all of this work that's been done for decades linking early life origins to later life health. And I agree with him that the shocks that have been studied are useful, but they're really specific to the groups that were impacted and the context. And so a lot of that work was on famine and war and a little bit on pandemics. But the focus on flooding or other weather events that are increasingly more likely to happen, I guess they're not increasingly more likely to happen than war, which is what I would have said about a week ago. But looking at things like economic shocks, currency devaluations, like these are things that are happening now in many countries around the world. So I thought that this was a really nice way to extend some of that theory, but then also to try it in different country contexts and with different policies. I thought this was a great extension in the Philippines. I did want to point out, I think Elijah mentioned that there was a rebound effect on BMI, and it sounded like he was struggling thinking about it as maybe a good thing. I wanted to point out that when you have people who are born with low birth weight and they rebound later, that takes a lot of energy and it's hard on the body. And so we actually think that that rebound that we see in BMI sometimes is actually not a great thing. I mean, it was something that needed to happen, and presumably it seems like it's good because they caught up, but the energy expenditure to catch up could have like later impacts on aging biology. So just to keep that in mind. And then I thought there was an interesting selection idea proposed here about maybe people who were exposed to prenatal stress are more biologically adapted, they become more biologically elite. I think there has been some work on this, particularly with famine and pandemic work, trying to understand what happens when you're prenatal development during these periods. And how do we think about that in terms of later life, like midlife and later life health outcomes? And so I think, Elijah, you could do some really interesting work here to try to understand this idea of this prenatal stress selection, potentially producing like more biologically elite babies, because those are the ones that survive to get into your data set. And then the other thing I think it would be great to, as you develop the work, is to really dig into that June versus June-August findings and why the June was so much stronger. Was it something specific about the flooding, for instance, and really trying to think through like how are these shocks shaping that prenatal stress? But I also just think a wonderful paper there in development. And in my comments, I'm going to group the last two papers kind of together. So I think that it's also reproductive aging research needs a bit of a renaissance. You heard from these presenters about the age at menopause being different in lower middle income countries than it is in high income countries. But actually, it's also been changing over time. And even in a country like the United States, it's different depending on which part of the country you're talking about. So studies using the regards data have found that menopause age is lower in the South than it is in the rest of the United States. So we kind of came up with this like typical age at menopause based on some, in some cases, pretty old data. I think it's time to update it. And I think it's very important that we don't assume that age at menopause in high-income countries should be the average age at menopause in other countries. So Hussein's work, I think, is really important. The use of the DHS surveys for this, I think, is really novel and a great way to revive this menopause timing research. So I think Hussein's paper was a nice methodological contribution. As he pointed out, it's not actually that straightforward to measure menopause in a population. It takes really careful attention to the questions that are asked on the survey, the ordering of the questions, and to pay attention to natural menopause versus surgical menopause. But even though the age at menopause was different and the prevalence of premature and early menopause was different, I thought it was interesting that education predicts early menopause in the same way in lower middle income country context that it does in a high income country context. And I was surprised by the finding with parity. However, I think what the factors that would go into a woman being childless sometimes are the same predisposing factors that impact health later. So some women don't have children because they're not healthy enough to have them, and then it makes sense why they would have earlier menopause. But having children in a low-income context might be a different physiological toll than it is in a high-income context. So I think, Hussein, it would be interesting to really try to pay attention to that, because that difference could have some really interesting implications for our understanding of women's reproductive experience and how it relates to their reproductive aging. Of course, it's hard. The one limitation of the DHS surveys is they stop at 49. So it is a little hard to estimate an average age at menopause because you're cutting off the right tail of the distribution. But I still think it's a really great use of these data. And then for the Osuna presentation, so both these speakers pointed out there's just not a lot of research on this topic in these lower and middle income countries. And of course, that's because, the focus is on reproductive lifespans at the earlier point of that and not at the later end. So I think it's really nice to see some additional work being done on reproductive aging, first in an Asian context and then with Osuna's work in Latin America. And I think there's some interesting signals there that early menopause conveys health risks in these populations as well. And it really does show the importance of focusing on reproductive aging in order to understand aging among women in general. So great job to everyone. These were really enjoyable to learn about and to see your presentations.
Thank you so much, Jennifer. That's terrific comments. Really appreciate that. Let's gather a few questions from the audience, and then we'll give each of you a chance to answer some of those questions, and you can respond to anything that Jennifer has said at the same time. So folks can raise their hand if you have questions, comments for any of the authors.
Okay, I guess if nobody wants to go, I could start a little bit to start the conversation going. I would like to go back to what some of Jennifer's comments for the last two presenters with the menopause, and also make the connection that for the cohorts that you are studying of women, those are the women who led the demographic transition in many of those countries, in particular with the reduction in fertility. And that is the case, for example, Latin American countries, the ones that I'm more familiar with, the cohorts that Margarita is studying, were the cohorts that just within a generation transition from a TFR, or total fertility rate, about 6 or so, to a TFR about 2. So it was a massive demographic transition. So Anwar already includes a little bit of parity in the analysis, but I'm not sure if Margarita has included it, but I would suggest you look a little more into those connections for the particular cohorts that you have. And if you haven't looked at those fertility trends, you might want to go back to Eileen's early work on fertility. You might not know, but Eileen did a lot of work in the some decades ago on fertility transitions. So you might want to go back to that to get an idea of how those cohorts in particular actually led some of those changes.
Yes, Hiram, that's exactly the second step to this project, is to start looking at that and to take into account other variables as well. Thank you.
Great. Others, Eileen.
Yeah, I don't want to talk about fertility, but and I had the exact same response as Jennifer to Sabari's paper on Pakistan and the heat and the lack of um, effect on the older population versus the middle-aged population. And I was wondering if you could actually look at how people spend their day differently by age to see whether you think that the older population actually does have an ability to regulate its activities in a daily fashion in a way that the middle-aged population does not, and or if there would be differences within the middle-aged population for people who could change their activities according to the heat versus other people who couldn't. Because that it seems like a very interesting finding from your work.
Thank you so much. The effects are stronger among 45 to 64 because this group combines high occupational exposure with rising maybe heart diseases, particularly in informal labor settings where heat protection is not very ideal. So basically, most of the people under this age is working in construction sector, informal labor markets, vendors. They are vendors, and so this could be one of the reasons. But definitely, I'll actually go back to the data and recheck it. Thank you.
Great, thank you. Mookie?
Yes, thank you. Hi, I have a question for the last two speakers. It's the same question. First, thank you for studying this important issue. So when you defining the timing of menopause, how did you address women with hysterectomy, especially those who only removed the uterus during the hysterectomy procedure because their ovaries are still there, but which means that they are still not yet being menopausal, but we just can observe their timing through the menstrual period. Thank you.
Margarita, should I go first or you want to answer?
You can go first if you want.
Okay. Thank you. Yeah, thank you very much for this question. So this is one of the major limitation of the DHS data. So as we found out in our study that higher parity is linked to earlier menopause transition. And as I mentioned, this is the first chapter of my dissertation. We want to build on these findings to the second paper of my PhD project. So in which we want to focus in depth that why we are seeing like a reversal of what we see in high income countries. And we have two plausible hypotheses. The first one is I want to call it like the biological exhaustion hypothesis. So where women in low and middle income countries, as they're getting married earlier, they're having higher number of children, that is parity, and more less interpregnancy interval, and they are also completing their desired family size earlier, around age 30. So when that desired family size is reached, particularly in India, we have the evidence that the insurance frameworks is designed in such a way that it is incentivized for the women who particularly belong to low and middle income, low and less educated group. They are incentivized to undergo hysterectomy. So you're right that when that hysterectomy occurs, only the ovaries still remain. That means the menstruate. But what happens 3 to 5 years post hysterectomy is the different kinds of gynecological morbidities, like the heavy menstrual bleeding or other pain, pelvic pains. So those women, they again go to these healthcare centers where they then have their full bilateral oophorectomy. That is, their both of their ovaries are also removed then. So at that moment, and currently we don't have the data to like trace that when the women are having hysterectomy in particular, and when they are having this bilateral oophorectomy, which puts them into menopause right away. So this is one of the limitation. And currently the DHS codes this question. They have these, like I mentioned, some numeric responses and also some categorical responses. So one of these categorical responses is whether the women had hysterectomy or not. So it can be a normal hysterectomy or it can be a bilateral oophorectomy. So there is no way to disentangle between these two processes. This is one of the major limitation of the DHS. But yeah, currently in my study we included both, like the definition earlier was suggested that according to World Health Organization, if the women did not have her menstruation for the last 12 months, this is the definition I used to categorize her as a menopausal within the limited data that we have in the DHS context.
Great, thank you, Anwar. Margarita, do you have anything to add on that?
I'll just very quickly say it's also a data situation, right? If the questionnaires didn't ask that question or didn't go into that level of specificity, it's hard for us to disentangle that. But I do think there is, the possibility of running the analysis one way with only women that said that had hysterectomy and women who said they did not have hysterectomy, and maybe do a comparison there if you really wanted to look into it a little bit more. But yeah, I'm with Anwar in that situation as well.
Great, thank you. Other comments, questions? I could take the chair's prerogative. Elijah, I dropped a question in the chat that you gave a partial answer to. I was just curious to hear more about seasonality in this context because we think about seasonality, many outcomes depending on the month of birth and how you're able to sort of measure that and think about it. I mean, I would have loved to just even see a very sort of non-parametric graph showing by month of birth your sort of key outcomes that would really help us understand this. You don't need an event study framework explicitly since you only have these sort of two events that you're analyzing separately. But do you have anything more you could add on how we should worry about seasonality here and how you've already dealt with it?
Yeah, of course, thanks. So the number of hot days during pregnancy is the measure of like heat stress that we're using, which by the end of pregnancy averages out to be quite similar. However, the distributions by trimester, so like what was the number in first or middle or late gestation
I think
does differ a
there's a
bit by
bad
group.
connection. Can other
So
people
what we've
hear him,
tried to
or
do
is
is
it?
like the number of hot days.
Yeah, sorry, Elijah. Your
Yeah, sorry,
connection's
it's storming in
unstable. We're not.
Chicago.
Yeah, without the video. See if you can try again.
Sorry, it's storming here in Chicago right now. So we've done some modeling trying to adjust for it, and then also we've just tried to look in descriptively, and we have some confidence in that, like since the no-shot group, we're seeing that they, were born larger at birth. They actually have a bit of a higher heat burden than the rest of the groups did, just because they were born in a time that was hotter, while there's actually a little bit less heat stress in the people exposed to the groups. So it's a little bit of like a counterbalance there, but we're trying to think best how do we look into this? So open to any suggestions that anyone might have.
Great. Thank you. I would just love to take your whole cohort by if you have date of conception or date of birth and just show these sort of non-parametric plots, just describing the data for each of your outcomes by month, I think would be really helpful. Duncan, did you want to add anything on that?
Yeah, just follow up. I will. I had exactly the same thought. And Elijah, I think it's a really extraordinarily impressive study and incredibly valuable. But I wonder whether it's worth looking at whether there's selection in who is getting pregnant when by maternal and potentially paternal characteristics. Because in this country, of course, there is tremendous selection in who gets pregnant in which season, in which month.
For sure, I think that and that's a really beneficial setup of this study being nested within a prospective birth cohort study rather than, linking to administrative data. We have such rich data on the characteristics of who are these people. So I think one way to do that could be looking in at some stratified analyses by maybe socioeconomic characteristics we might think matter. Today I didn't present the first and second trimester work looking at this because then this is a separate selection issue, but we'd be worried more about fetal culling and selection in utero there. But certainly a great place to look into next. Thank you.
All right, we have one more minute. If there are any last comments or questions or responses. Well, these are fantastic studies. I'm really looking forward to seeing them as they evolve and get published. So thank you to all of the presenters and to Jennifer for the fantastic discussion comment.
So we're going to begin the session on cognitive aging. And our first paper is going to be by Eleanor Roalt on childhood roots of the aging brain. Eleanor, can you share?
Okay, so thank you for being here and having the opportunity to present this work, and thank you for all the presentation before that were very, very interesting. So I'm a postdoctoral researcher at CIRED in France, and I'm an economist focusing on aging in China in particular for this paper. So this paper is related also to the presentation before on early life determinants of cognitive aging. So as you probably know, most of low and middle income countries already account for more than 60% of dementia cases and 80% of mental health disorders. So that said, we know very well the short-run determinants of dementia and depression, but little is known on the long-run determinants. And in particular, in this framework, we know that early life environment shape cognitive, physical, and social-emotional development with lasting effect in adulthood. So since most evidence focusing on children and adults, it is required to study more what happens in old age, in particular due to the fact that some effects may disappear over time, or on the contrary, some effects may be latent and observable until a given age, after a given age. So in this paper, I'm wondering how do early life weather shocks affect the level and the slope of cognition and mental health in old age. So I'm using weather shocks as a proxy of early life circumstances. A particular feature of the paper is that I test for critical timing, that is to say periods that shape more than others long-term outcomes. The data I use are charts from the HRS family surveys specific to China. And the identification relies on the exogenous monthly variation in extreme weather conditions based on a climate index called the SPEI during each of these specific periods, so the prenatal period, the period from birth to 5 years old, and finally from 5 to 15 years old. The empirical strategy relies on a simple two-way fixed effect. I study the outcomes both in level, relying on a cross-section analysis, and on cognitive and dementia on mental health slopes or dynamic in longitudinal approach. This paper contributes to different strands of existing research, but I will focus only on two of them. The first is the literature on longitudinal evidence on aging trajectories. So as mentioned before, this literature is very small, and I found only one paper in economic literature who identified, this paper of Vandenberg and co-authors, who identified that early life circumstances may shape cognitive decline in old age in high-income country setting. The second contribution is related to the critical timing period, and in that respect, I contribute to the paper of Webb, who find that age 2 shape more than other ages long-term outcome in adults in Indonesia. So regarding the data, I use different outcomes provided by Charles. Regarding cognitive outcome, I use serial 7 test. Some of you may know this standardized test, which is a proxy of the working memory and consists in asking to the respondent to subtract 5 times 7 from 100. I use also the world recall test, which is a combination of immediate and delayed recall test and capture episodic memory. To ensure comparability of outcomes across waves, despite the fact that some waves are differing from others, I follow the methodology of Wu and co-authors who show that we should use some adjustment weights depending on the wave of interest. Regarding mental health outcome, I use a CSD scale, which is also a standardized scale for depressive symptoms, which provide the frequency of symptoms among 12 items related to depression, and the score runs from 0 to 30. So the higher is the worst, which is not the case for cognitive outcomes. So here are the distribution of outcomes of interest. To allow comparison of each of these outcomes, I standardize them. So they have the mean of 0 and standard deviation of 1. Here I plot the distribution across ages and gender of each outcome. And we see that both males and females suffer from declining of memory skills over age from 50 to 80 years old. Regarding other outcome, we clearly see that women are more vulnerable, both regarding cognitive loss, numeracy more precisely, and also regarding depressive symptoms. Regarding weather data, I use the SPEI. So SPEI is a kind of balance between rainfall and evaporation. And I considered two thresholds of this value that is standardized at the local level, at the prefecture level, where I measure the shock. And I consider the drought when the SPEI is below a threshold and above another threshold. I provide robustness check relying on other thresholds. The key interest in using SPEI is that there is no serial correlation over time of this index. So one index does not predict the next one. And I can ensure that in the same equation, different shocks are not multicollinear. So I can identify precisely the window of exposure that shape long-term outcomes. So at this stage, you may wonder how I deal with selection. So there are multiple sources of selection that may bias the estimate. I will detail just two of them, the main ones. The first concern is related to selective mortality. So as we mentioned before, if shock disproportionately kill weaker children, the surviving sample is positively selected, and in that context, I argue that I estimate a lower bound of the true effect. There is also a selection from the Charles sample. I exclude from the analysis different types of individuals, in particular migrants before age 16, urban Ukhu holders for those who know China, and those who were born in too large area so that I cannot ensure the acute assignment of weather shock. There is also concern related to the fact that I dropped proxy interviews, and we may have some concern regarding the representativeness of the study sample. So to correct for this selection, I use IPW methodology. So I adjust baseline Charles weights. So regarding the cross-section analysis, I regress the outcome of individual E born in prefecture P at time T on different window shocks. I include controls and fixed effects, and so on and so forth. And I will present after the longitudinal approach. So results regarding cross-section, so in levels, we see that prenatal shocks do not affect significantly outcomes, while shocks, so one standard deviation increase in space shock from birth to 5 years old results in a lower shock, in a lower memory score by 0.045 standard deviation. So the magnitude is quite the same as the result previously found in a close paper. So the result is similar for numeracy, and for shock from 5 to 15, they are like a puzzling effect, reduced memory but increased numeracy. I will discuss that after. Longitudinal analysis is quite similar. Exploit in this version the within individual variation in age. So in this specification, I include individual fixed effect that absorbs the unobserved heterogeneity that is fixed over time. So to capture a variation from shock, I need to interact them with age, and I capture the variation every year that affects the individual. So here, the results. So one standard deviation increase from birth to 5 years old in weather shocks increase each year in the study sample the CSD scale, so the depressive symptoms, by 0.05 standard deviation. So this effect could seem very small, but it's a yearly level. So at the end of the day, when you reach 80 years old, the effect is quite large. So I try to disentangle mechanism. I will not present all of them, but I study migration and years of education. I will present only years of education. And what we see is that weather shocks reduce years of education when endured from birth to 5 years old. And if we interact shocks by gender, so I try to disentangle the gender effect of education, we see that shocks from 5 to 15 years old increase schooling, increase years of education, which may explain the puzzling effect we have for this period from 5 to 15 years old. And this mechanism is consistent with previous results, in particular the paper from Stein-Steinberg, who shows that there is a reduced opportunity cost of schooling due to weather shocks. So I conduct different robustness checks. I will not discuss them, but we can discuss them in the discussion. To conclude, the key findings are the following. Exposure from birth to 5 is critical in shaping long-term cognition level. Exposure from birth to age 5 also steepens the slope, so the dynamic of depression scores, and provide evidence of an early life influence on mental health. Finally, offsetting mechanism during late childhood, specifically education and migration, may contribute to the puzzling effect and also suggest that late childhood may be as critical as the previous periods. So this paper had different policy implications, but broadly speaking, it reminds that intervention during early childhood may have substantial effects on long-term outcomes and be more cost-effective as previously estimated through reduced long-term care and improved well-being. So thank you for your attention, and sorry for the messy starting.
That was very interesting. Thank you, Eleanor. I look forward to the discussion of some really interesting results there. So now we'll go to the next paper, Sangha Hyun.
Yes.
Cross-national associations between cognitive functioning and mortality risk, the US, India, and Mexico.
I believe you can all see my screen.
Yes.
Thank you for attending my talk. Today, I'll be presenting our study titled Cognition and Mortality Risk Across the United States, Mexico, and India, Evidence from the Harmonized Cognitive Assessment Protocol. My name is Sangha Jeon from University of Michigan, and listed are my co-authors contributing to this project. Cognitive functioning is an important indicator of brain health in older adults. Cognitive decline may reflect underlying brain changes in brain health like neurodegeneration or vascular problems, and these brain changes often come together with frailty or other bodily problems. And these brain changes underlying cognitive decline can make individuals more vulnerable to a wide range of negative health outcomes. Therefore, individuals experiencing cognitive decline are thus at higher risk, not only for illnesses or frailty, but also for mortality over time. Many studies show that individuals with cognitive decline have a higher risk of death, and this supports the idea that cognitive functioning can be a strong predictor of survival in later life. To understand cognition, it is helpful to consider it as a multi-dimensional construct consisting of multiple domains. So 5 key domains can be orientation, language, memory, executive functioning, and visual spatial functioning. And considering these domains separately can help us to understand whether specific aspects of cognition can be more strongly associated with mortality risk than others. When we look at how individual cognitive domain relates to mortality, the evidence is mixed. So for example, impairments in orientation and executive functioning tend to consistently predict higher mortality risk across studies, but findings for language, memory, and visual spatial functioning are kind of mixed. So some studies show associations while others do not. However, it is important to interpret this evidence within its broader context. Although there's a growing research from low and middle income countries, the majority of the previous studies have been conducted in high income settings. Moreover, direct cross-national comparisons are still limited. So this is important because variation across national contexts, such as healthcare systems or social infrastructure, may shape how strongly cognition can be related to mortality. So to address these research gaps, our study aims to investigate the cognition and mortality association across the US, Mexico, and India, countries with varying healthcare systems and social structures. And we use the Harmonized Cognitive Assessment Protocol, HCAP, a standardized and culturally adapted cognitive battery implemented across countries. So this framework enables comparable assessments of both global and domain-specific cognition across high, middle, and low-income countries. Our team has two hypotheses for this study. The first hypothesis is that both global and domain-specific cognition predict mortality in the US, Mexico, and India. And we also hypothesized that the associations may vary across countries. We used the data from the Harmonized Cognitive Assessment Protocol, specifically HRS-HCAP in the United States and MaxCog in Mexico and La Ciudad in India. The HRS-HCAP sample includes around 3,300 participants. On average, they were 76 years old, and more than half were female, and the majority had upper secondary education or higher. And approximately 24% were reported deceased during the 7-year follow-up. And the Mexico sample, the MaxCog sample, includes about 1,400 participants after restricting the baseline sample to those who are aged 64 and older to ensure comparability with HRS-HCAP. And their average age was 73, and more than half were female, and only 9% had upper secondary education or higher. And about 23% were reported deceased during the 6-year follow-up. Lastly, the La Ciudad sample includes roughly 3,000 individuals, again restricted to those aged 64 and older at baseline, and the average age was 72, more than half were female, and 70% had upper secondary education or higher. And around 27% of them were reported deceased during the 7-year follow-up. For the measures, as I mentioned in the introduction and hypothesis, we are testing both global cognitive functioning and domain-specific cognition, and we ran it in separate models. So general cognitive performance, GCP in HCAP, is the summary score of global cognition in each study. And each study created HCAP GCP scores using comparable methods. And domain-specific scores were derived with CFA in each study, except for orientation and visual spatial functioning in HRS-HCAP. So for these two domains in the HRS-HCAP, we used the raw scores and standardized them, as CFA-derived scores were not available. For mortality risk, for the people who are deceased, survival time was calculated based on the number of months from the HCAP interview to the date of death. And for those who are alive in the follow-up, their survival time was defined as the number of months from the HCAP interview to the last follow-up date. We included both demographic and health-related factors as covariates. For the demographic factors, they included age, sex minority status, education level, marital status, and household wealth. And health-related factors consisted of the number of chronic illnesses, BMI, smoking status, binge drinking, and depression. To examine the relationship between cognition and mortality risk, we conducted Cox proportional hazard model in the United States, Mexico, and India. First, we looked at general cognitive performance in each country separately. And then we examined domain-specific cognition scores, including orientation, language, memory, executive functioning, and visual spatial functioning, again, modeling each country independently. And these are the results to show the relationship between general cognitive performance and mortality risk across 3 countries. As you can see in the slide, on the x-axis, we have the hazard ratio, and on the y-axis, each country. And let's start with the United States one, the red one. The hazard ratio is 0.56, meaning that 1 standard deviation increase in general cognitive performance is associated with 44% lower risk of mortality. And in Mexico, the hazard ratio is 0.36, indicating a 64% lower mortality risk per unit increase in cognitive performance. And in India, the hazard ratio is 0.6, corresponding to a 40% lower mortality risk per unit increase in cognitive performance. Here, we also examine the relationship between domain-specific cognitive performance and mortality risk across countries. Now, on the y-axis, we have each cognitive domain, and each line represents a country. So overall, lower cognitive performance was associated with higher mortality risk across all domains and across all countries, as we can find that the hazard ratios are below 1. And while hazard ratios appear to differ slightly between countries, the effect sizes seem to be generally comparable, and confidence intervals overlap, suggesting similar associations across the US, Mexico, and India. Overall, both general and domain-specific cognitive performance predicted mortality risk across countries. Although we have not formally tested whether the differences in hazard ratios across countries were statistically significant or not, effect sizes were broadly comparable with overlapping confidence intervals across most domains. And these suggest that the negative association of higher cognitive performance with lower mortality risk is generally consistent across sociocultural contexts, despite the potential differences in healthcare access or support systems. Before I end the presentation, I'd like to highlight a few limitations and future directions of the study. First, our study has an observational design, so we cannot establish causality. Second, cognitive performance was assessed only at a single baseline time point, which limits our ability to examine changes in cognition over time. So based on these limitations, future studies could examine longitudinal trajectories of cognitive decline and their associations with mortality. And we are planning to conduct formal cross-national comparisons of effect sizes. And in addition, you can also incorporate functional impairment alongside cognitive impairment to better understand how cognitive and functional impairment together relate to mortality risk across countries. Finally, I'd like to thank my team and colleagues for their support throughout this project. And I also want to acknowledge that the many funding sources that made this work possible. So please feel free to bring up any questions or discussion points during the Q&A session. And if you'd like to reach out or have questions later, you can just scan the QR code here on the screen to get my email. Thank you.
Thank you, Saha. It's a very nice presentation of harmonized data, something that we've been wanting for a long time. So now let's go to our third paper. It is by Rosina Sarin, and it's on cognitive impairment and depressive symptoms are associated with all-cause mortality among older adults. And this is going to be on a study from the Philippines.
Just to check, are you able to see my screen and hear me well?
It looks good. Rosina.
Okay, great. Thank you so much. Yeah. So, hi everyone. I'm Rosina. I'm a year one PhD student from Duke NUS Medical School in Singapore, and I'll be sharing on the findings from a longitudinal aging cohort in the Philippines, also known as the LSAP, specifically on cognitive impairment and depressive symptoms. So starting off, as we've seen from past presenters as well, aging populations are not only specific to high-income countries, but definitely in LMICs as well, which are set to account for 80% of those aged 60 years and above. Specifically in the Philippines, older adults above 60 years are projected to comprise more than 10% of the population by 2030, which would classify the Philippines as an aging society according to the UN definition. So which means that the next 4 years are a particularly crucial time frame in preventing and managing age-associated health burdens. So specifically, depressive symptoms and cognitive impairment both increase by age and also increase all-cause mortality. And importantly, they account for a greater burden, as mentioned previously, in the LMICs. So for example, in the Philippines, 1 in 3 older adults have depression. However, treatment gaps still remain suboptimal. And now a comorbidity of depression and cognitive impairment is actually said to affect 1 in 4 older adults above age 85. And why this is important is because both of these conditions have commonalities in their risk factors, as well as in their clinical manifestation and downstream impact on other NCDs and mortality risk. So having established this disproportionately higher burden, few have looked at the interactive effects of depression and cognitive impairment on mortality. And specifically in the Philippines, I would like to highlight a few unique challenges that it faces. So for example, climate disaster risks are a key concern and unique stressor in the Philippines, especially. There is also social stigma in help-seeking behaviors for mental health. And there is a distinct disparity in healthcare access between rural and urban settings, as well as what was mentioned earlier on an upcoming aging society. So therefore, we really aimed in this study to have an exploration on the independent and interactive effects of cognitive impairment and depressive symptoms on all-cause mortality among older adults in the Philippines. So as mentioned, the data source was from the longitudinal study on aging and health in the Philippines, which is a cohort of older adults. And the baseline wave data collection was done in 2018-2019. And the follow-up data was collected in 2023, early 2023, which is when the mortality outcomes was assessed. And basically, the cohort has a sample size of 5,985 older adults. So for the measures, we use the CESD-11 scale, which is a Center for Epidemiological Studies Depression scale, the 11-item scale for depression. And we summed it up to get a range of 0 to 22, and higher scores indicating more depressive symptoms. And we also used a categorized measure where a score of more than 7 will classify one as having clinically relevant depressive symptoms, or CRDS. For cognitive impairment, we use the SPMSQ, which assessed components of cognitive function. And a greater number of errors in the question in this measure would indicate a greater cognitive impairment. So if there is a higher score, it basically means that they have higher cognitive impairment. And we also used a categorized version of this score, which would allow them to have a range of no, mild, moderate, and severe cognitive impairment. And this categorization was also adjusted for education level based on the 5 first criteria. So finally, for the outcome, mortality, it was assessed at the follow-up wave, where the mortality status was assessed as well as the date of death was determined. And follow-up duration for those who were alive was determined from the baseline date of recruitment up to the follow-up interview. So moving on to the analysis, we had some missing data on the cognitive impairment scores and the depressive symptom scores, and we used multiple imputation to impute for this missing data. And following that, we performed logistic regression and Cox proportional hazards model, which were adjusted for confounders and also weighted. And we also tested the proportional hazards assumption, and sensitivity analysis was also done. And Lastly, for the time to event data, as we mentioned, the death status was ascertained at follow-up time point. And for the date of death, a small proportion of participants had the date of death missing. And so this was imputed as the midpoint between the baseline interview date and the follow-up interview date. And for those who are alive, also a small portion had their follow-up interview date to be missing, and therefore they were unable to be included in the time to event analysis in the Cox models. So moving on to the results in the cohort, most of them were female, about 70 or 79, and they had a low level of education and mostly resided in rural areas. Most of them also lived with their children and were married and not working, meaning that they were either retired or unemployed or homemakers. So visualizing the results, you can see from this heat map that with a higher proportion of, we see a higher proportion of deceased with higher depressive symptom scores and higher cognitive impairment. Yep. And moving on to the Cox logistic and Cox models, you see here that we do see a 5% higher risk of mortality with every unit increase in depressive symptom score. However, interestingly, when we use the categorical measure, which was the CRDS, we didn't see a statistically significant risk of mortality. And for cognitive impairment, similarly, with every unit increase in the cognitive impairment score, there was 14% higher risk of mortality. But again, when we looked at this from the categorical variable for cognitive impairment, from no, mild, moderate, and severe, the higher risk of mortality was not statistically significant. So looking at the interaction effects also, when we looked at both the continuous scores as well as the categorical version of the variables, there was no statistical difference. However, we do see when we look at the, when we use the scores to assess this, that even without an increase in depressive symptom score, an increase in cognitive impairment scores actually did increase mortality risk by 16%. So to sum up the findings in one glass, since we've gone through a few findings already, in summary, with higher depressive symptoms and higher cognitive impairment, we do see higher mortality risk. And however, these risks were not replicated in the categorical versions used of the depressive symptoms and cognitive impairment. And the interaction effects were also not significant. So to kind of make sense of this and to discuss this, what we did see, for example, for the depressive symptoms is that the scores, when we use the scores, we do see a higher mortality risk, but this was not replicated in the categorical operationalization of this. So this does tie in with past evidence that when we oversimplify depressive symptoms as binary instead of gradient or continuum, that may not be helpful. And rather, we should be treating depression as a continuum and gradient. And additionally, it has also been shown using this very scale for SESD11 that even at participants who do not meet the cutoff scores to be classified as being depressed, they do show high risk of mortality, which reasserts the point that we need to encourage earlier help-seeking behaviors right at the early end of this depressive symptom spectrum. And also, one thing to note is that the cutoff for this SESD11 scale was not validated in the Filipino population, so we're not sure if this is sensitive in the local social cultural context. And regardless, the higher risk of mortality that we do see with depression reasserts the need that we need to ensure effective implementation of the Philippine Mental Health Act in 2018, which was originally intended to ensure allocation of financial resources and stakeholder engagement to ensure community mental health interventions are rolled out to detect depression and intervene at an early stage. So for cognitive impairment, we do see a higher risk of mortality, and this is very commonly seen in parallels other similar Asian settings as well, which indicates the urgent need for earlier diagnosis and management. However, in the Philippines, currently, national health insurance plans remain limited and inconsistently accessible in terms of routine diagnostics and screening of dementia, which could put a financial strain on older adults and their caregivers and deter early recognition. So what this could do is to perpetuate dementia risk and even go down the spectrum of patients having poor medication adherence or increased frailty, which eventually further increases mortality risk. So for the interactive effects, while we didn't see any significant effects between depressive symptoms and cognitive impairment in influencing mortality, one thing to note is that different scales or measures have been used each time in detecting these interactive effects, which can influence downstream sensitivities in assessing any interaction effects. And additionally, another point to note is that past evidence has shown different risk factors and trajectories for those with or without depression and with cognitive impairment. So for example, in those with pre-existing depression, the cognitive decline can be more attributable to imbalances in neurotransmitters versus, for example, those without depressive symptoms and only cognitive impairment. Cognitive decline later on could be attributed to age-related changes in brain. And additionally, this particular subpopulation could have lesser impetus to seek medical attention if they do not see earlier depressive symptoms in their cycle. And so what this means is that we need to look at common risk factors across cognitive decline and depression and use community-based programs to engage in screening and social engagement. So with that, this has been the first to, within the LMIC Southeast Asian context, to look at depression and cognitive impairment. And we also performed a sensitivity analysis with the categorical measures, and we did multiple imputation to account for missing data. However, we do wish to acknowledge limitations where, for example, the proportional hazard assumption was not fully met, which means that mortality risk may not be proportional over time. So future studies could have multiple follow-ups or have time-axis division to ascertain the changes in risk over time. And lastly, we also had some missing information for the date of interview or the exact date of death, which was missing. But this was a rather small proportion, so which may have low influence on the precision and risk estimates. So with that, I would like to send my appreciation to my supervisors and mentors, Prof. Rahul and Prof. Jules, as well as everyone in the LSAP study team in the University of the Philippines. Yeah, thank you very much.
Thank you. I think I'm seeing a trend here with cognition and depression in the same papers, which is very interesting. And you certainly have a new generation of slides there, Rosina. So now we'll turn to the next paper by Muki Gao, and it's on long-term impact of a cash transfer intervention on depressive symptoms among older adults in rural South Asia. Muki? Yeah. Good.
Oh, thank you, Eileen. Hello, everyone. It's a pleasure to be here. Today, I will present our study examining the long-term impact of a cash transfer intervention on depressive symptoms among older adults in rural South Africa. Depressive symptoms are highly prevalent among older adults in rural South Africa. Up to 30% of adults over age 40 experience elevated depressive symptoms, and the prevalence increased substantially with age. High depressive symptom burden is also associated with worse cognitive function, functional disability, poor quality of life, and multiple chronic conditions. And depression has also been identified as one of the 14 modifiable risk factors for dementia. South Africa's National Mental Health Policy Framework emphasizes the importance of multi-sectoral and evidence-based strategies for improving mental health. Social protection programs such as cash transfers may represent one potential policy tool. There are several potential mechanisms through which cash transfers may impact mental health. On the positive side, cash transfer can improve income security, food access, and healthcare utilization. They may also reduce financial stress and increase the household consumption, which could finally improve psychological well-being. However, there may also be potential negative mechanisms. Conditional programs may introduce stress related to the compliance requirement, and receiving assistance may sometimes carry social stigma. South Africa provides an important context to study these dynamics. It has one of the largest social grant systems in the Global South, with nearly 45% of population receiving some form of social grant. Existing evidence suggests that cash transfers can reduce depression and anxiety in the short term, particularly for the unconditional programs, and this effect often attenuates once the program ends. Within South Africa, previous studies have suggested a mental health benefit from several cash transfer programs, particularly among younger population and older men. But however, there are still important evidence gaps. In particular, we know little about the long-term mental health effect after the program cessation and the effect among all older adults, and whether these effects vary by socioeconomic characteristics. Our study will address these gaps. And specifically, this study addresses two research questions. First, do older adults exposed to a cash transfer program experience different long-term depressive symptoms compared with those not exposed? And does this relationship vary across socioeconomic characteristics, such as education or household resources? And this study uses two population-based data set collected in rural Mpumalanga province in South Africa. And this region is a typical rural settings in South Africa, characterized by low education attainment, high unemployment, and limited infrastructure. The first data set is HALSEY. It is a longitudinal cohort of more than 5,000 adults aged 40 and older. The study collects rich and longitudinal data on health behaviors, socioeconomic conditions, and household composition. And the second data set is a HIV prevention trial network called HPTN 068 trial. It is a randomized controlled trial designed to reduce HIV risk among adolescent girls and young women. Participants were unmarried, non-pregnant young women aged 13 to 20 who were enrolled in grades 8 to 11 at baseline and their primary caregivers. Participants in the treatment arm received 3,000 South African rand per month, conditional on maintaining at least 80% school attendance in the preceding months. This amount represents a meaningful increase in household income compared to the local per capita consumption level. To study the long-term impact, we linked the HALSEY participant to the HPTN 068 trial data at the household level. Our analytic sample include 862 HALSEY participants. About half of the sample were directly randomized into the trial, while the other half lived in household with at least one trial participant. So we used an intent to treat design. Participants were considered exposed to the intervention if they were either directly randomized to the treatment group or lived in a household with an individual randomized to the treatment. This approach assumes within household sharing of resources, which is consistent with the previous study using this data. Our final analytic sample include 433 individuals in the control group and 429 individuals in the treated group. The outcome is depressive symptoms, which were also measured using the Center for Epidemiologic Study Depression Scale, the CESD score. And the figure shows the timeline of exposure and outcome measurement. So the cash transfer intervention payment occurred between 2011 and 2014, while the CESD outcome were measured afterward during the HALSEY data collection. CESD score in HALSEY has some comparability issue across waves. Because HALSEY changed the CESD version after baseline data collection. The two versions are different in number of items of the CESD items and the responses option of each item. So we therefore conducted cross-sectional analysis at wave 1 using linear regression and longitudinal analysis for wave 2 and wave 3 using linear mixed effect models. We also examined the effect modification by several social demographic characteristics, program implementation information, and eligibility for other social grants. So here are some results. Table 1 shows the descriptive characteristics of the study sample. As we can see, the treatment and control group appear balanced across key social demographic characteristics. And the table 2 shows the program implementation information. On average, the time between the last cash transfer payment and the housing baseline survey was about 20 months. And nearly half of participants received transfers for more than 2 years. And the eligibility for other social grant was similar between treated and control groups. Here is the main analysis effect. Overall, we found no statistically significant long-term effect of the cash transfer intervention on depressive symptoms, either at the baseline CESD measurement or in the longitudinal follow-up. And there is no significant variation in effect across subgroups except by education. I didn't show all the subgroup results, but I will highlight the effect modification by education for the relationship between the treatment effect and the baseline CESD score. As we can see, among individuals without formal education, treatment exposure was associated with a higher CESD score. This is about a 37% increase compared to the control group. And among individuals without with formal education, the association reversed the direction, suggesting slightly lower depressive symptoms among the treated groups. So to summarize, we found no overall long-term effect of the HPTN 068 cash transfer intervention on depressive symptoms among older adults in rural South Africa. However, education strongly modified the association. Individuals without formal education appeared to experience adverse long-term mental health consequences after the program cessation. So why might we observe these patterns? First, our study captured the mental health outcomes after the intervention ended, with the first CESD measured occurring about 20 months after the final payment. And the now overall effect is consistent with the previous literature, suggesting that the cash transfer effect may diminish over the time. But education may act as a buffer, shaping how households can translate economic resources into psychological well-being. Participants without formal education may face greater challenges in coping with the loss of cash transfer income, which could finally contribute to worsening depressive symptoms. And this study has two major limitations. First, we lack CESD measurement prior to the intervention and during the intervention, which limits our ability to evaluate the short-term program effect and longitudinal changes of depressive symptoms. Second, the CESD CESD scale differs across survey waves, which limits direct comparability across waves. But these findings have potential public mental health implications. So to improve the mental health, social programs may need to be integrated with the economic intervention, particularly during the program cessation period and for individuals with lower education attainment. Further research should examine mechanism linking cash transfer and long-term mental health effect, as well as the role of education as a modifiable factor. This analysis was supported by a NIA-funded project with Dr. Molly Rosenberg and Dr. Lindsay Kobayashi as the co-PIs. And I'm also thankful for all my co-authors, which had contributed significantly to this analysis. And finally, thank you all for your attention. I look forward to the discussion, questions, and comments. Thank you.
Thank you, Mookie. Duncan Thomas now, who's been a long time member of this group, both contributing papers and as a discussant. Duncan, you've got your work cut out for you.
I have. Can you see my slides?
Yes.
Good.
And guess what? They're PDF, right?
It's shocking, isn't it?
I
Totally
guess you're
shocking.
a card-carrying economist too.
I am. And they actually go forward. All right, very good. Thank you so much. I have a very easy task. I had 4 terrific presentations to discuss. And what's really, really easy about them is 2 of them are very, very similar, and the other 2 have quite a lot of similarities. So I'm going to talk about them in sort of pairs. I'm going to first talk about Sangha and Rosina's study. Both of them document associations between mortality on one hand and cognition and depression symptoms on the other. Both are extremely well designed, thoughtful, very insightful investigations, and terrific presentations. I don't have a lot to say about these. So let's talk first about Sangha's paper. It very effectively leverages comparable HCAP data from 3 different contexts and establishes mortality hazards are remarkably similar for each domain of cognition. And the reason this is so surprising, and it was in their hypotheses, they did not expect them to be very similar, is that the contexts that these people are living in are so dramatically different. And I think, one can say, well, cognition is just this generalized marker and we can draw these conclusions that these are predictive of subsequent mortality. I do think it's worth thinking hard about why you're getting such similar results, especially when you look at each of the different dimensions. But when you look at the general cognitive measure, actually Mexico sticks out as being significantly different from the other ones. And the big difference in the components is actually in orientation, which, by the way, is different in HRS HCAP and MHAS HCAP, and I think India HCAP, because they're having to ask slightly different questions. So you sort of wonder what's really going on underneath this. And this clearly is part of the program Sangha and collaborators are engaged in. And I think this is a truly excellent and thought-provoking study, and I look forward to seeing more. As Eileen said, these studies are very comparable data sets that we can draw conclusions from across the globe are extraordinarily valuable for understanding what might be underlying the patterns we see in the data. The second paper,
Duncan, can I interrupt just for a second? I wasn't sure if you had slides that were supposed to be moving. We're seeing a Word document right now.
Let's try again.
It's a PDF. Right?
Are you seeing a
Now
PDF?
we're seeing slides. Yes.
Okay.
And are the slides going forward?
Yes.
Oh, yeah.
Yes.
Oh, sorry.
Oh, great. That must have been a very complicated thing for you to have understood.
Well, it was harder without the pictures.
I'm sure. I was looking at the pictures. I'm very, very sorry. Well, I'm not going to go and repeat them.
Well, thank you,
I'll
Will.
be happy to talk about them with you, Sangha, afterwards. Let me carry on to Rosina's paper. I have very little to say about this. This just uses a very interesting data set from the Philippines, and the heat map was just too compelling for me not to reproduce. It establishes cognitive impairment and depression symptoms do predict subsequent mortality. It really feels like cognitive impairment is the big item. And again, I think the question is why. And the reason I ask that is that, of course, it could be that cognitive decline and getting more depressed causes people to die, in which case I think your discussion about policy implications is very well placed. But it's also possible that these are just markers of reduced functionality that portend end of life, much as biological markers do, in which case I'm not sure the policy implications are as clear. And I think we really want to try to separate those 2 types of explanations from one another. It's not to say there shouldn't be ways to improve people's cognitive performance, reduce depression, etc. But let's not conclude they will causally reduce mortality unless we have evidence of that. And I think that's a super hard problem, and one of the reasons I'm especially excited about these comparable studies across countries. Okay, let me turn next quickly to the other two papers, Eleanor's and Mookie's. Both of these studies aim to identify the causal effects of resources on cognition and depressive symptoms, in one case using a natural experiment, and the other case using a randomized control trial. Let's start with Eleanor's. She uses a natural experiment. She uses a weather shock, how many months you were exposed to having extreme high rates of rainfall or low rates of rainfall. And I'm going to just show a quick result. The cross-section result shows that there's a negative impact of extreme rainfall, either drought or excessive rain, both on memory, if you're exposed between age 0 and 15, and on numeracy, if you're exposed between 0 to 5. There are many, many things to like about this paper. It's a extraordinarily carefully done series of robustness checks, very, very, very impressive work. However, the thought that I had when I read it was I feel it's imperative that we establish the weather shock, as she calls it, is indeed a shock. That is, we need the high variance areas in China to be exchangeable with the low variance rainfall areas. And why do I think this is important? Well, there's a famous study that you cite by Armand, which documents that in utero exposure to 1918 Spanish flu has a causal negative impact on completed years of education of adults. And of course, what that study assumes is that the surrounding birth cohorts are exchangeable. And if the surrounding birth cohorts are exchangeable, it must be the case that the fathers of those birth cohorts have the same level of human capital. They must also be exchangeable. The 1918 Spanish flu couldn't possibly have changed fathers' education, etc., but it did. The fathers of the 1919 birth cohort have less literacy, lower occupation scores, and worse socioeconomic index, i.e. exchangeability is violated, and almost surely what this reflects is selective fertility at the end of World War I. And the problem, I think, with lots of these natural experiments is that you might worry that those who lived in high and low rainfall variance areas in China are not exchangeable. I'm from Zimbabwe. I can assure you, people who live in areas where there's very high variance in rainfall are not the same as people who live in areas where the rainfall is less unpredictable, has less variance in it. And what a good discussant will do is make some constructive statements that hopefully you could think about. And that is, can you actually check? There's a lot of robustness checks, but not of this sort in the paper, but not of this sort. Can you check whether weather variability is a shock? So one potential route would be to look at the parents of the people in the study you're in Charles, and do the characteristics of those parents, their socioeconomic status, their education, and so on, vary with weather shocks? Because if they do, you don't really have weather shocks. Alternatively, or in addition, you look at in utero 0 to 5, 5 to 15, you could also look at preconception weather shocks. They should not affect these outcomes. And thirdly, using the biology of linear growth, we know that height is largely determined within the first 1,000 years. So the shocks that occur between 5 and 15 years should have no impact on height. And height is measured in Charles. So those would be ways for one to investigate the validity of that really critical assumption. And again, a really impressive, and I think it will be an important study. Okay, last set of comments briefly. A Mookie study, I think I understood how it was done. I'm not sure, and if I've got this wrong, forgive me, but she uses an RCT to identify the causal effects of income on depressive symptoms. 13 to 20-year-old girls were randomly assigned to either receive a treatment or control. The treatment was huge. This was 65% of per capita household consumption on a monthly basis for up to 2 years. If these people did not get a ton of income as a result of that, that's sort of shocking. So you would think that even if they, after a few years, this very large increase in income would have a positive impact on CSD scores. So the big result, I think, is that Those who are eligible and had some formal education, there's an interactive effect, which ends up being there's no difference for them whether they got the treatment or not. The main result, I think, is that for those who are eligible and had no formal education, they have higher CSD scores in the post-intervention studies in Halsey. And that's sort of sad and depressing. Give people a 65% increase in household resources, and you cause them to be more depressed. So there's some discussion in the paper, in the slides, that maybe the girls didn't attend school, maybe they kept their dollars, they didn't share them with their rand, they didn't share them with our household members. In general, sort of maybe the girls did something, there were some behaviors of the girls that made the other household members depressed. Let me suggest an alternative explanation, which is maybe as a result of this colossal increase in income, there was a change in household composition in response to the rand, to the dollars. And for example, one possibility is that older adults who are in poorer mental health, excuse me, joined the household. If those older people joined the household, that would cause a decline in the health of older adults overall. And this generally, just like natural experiments are a tough, it's tough to assure the natural experiments is truly an experiment. With an RCT, there may be behavioral changes that we do need to think about. We're not giving them a pill and a placebo that are identical, and there may be behaviors at the household level. This is especially important in South Africa, where living arrangements are very fluid. And indeed, it's something you could check, because you can check household composition in the Halsey data. It's not just a theoretical idea. Duflo has a famous paper, Duflo, who won a Nobel Prize. Actually, Deaton has a parallel paper. He also won a Nobel Prize. And Duflo examined grandmothers who became eligible for the old age pension. So that wasn't randomized. But she showed and concluded that granddaughters of these grandmothers, when they became eligible, after they became eligible, the granddaughters were taller relative to when the grandmothers were not eligible. And so it concluded that this was a causal effect of the OAP, old age pension, and the grandmother was transferring resources to the granddaughter. The problem is that adults in these grandmothers' households were also taller and better educated after the grandmother became age eligible, in which case what we're seeing is household composition changed exactly because these grandmothers now had a whole lot of money and they could draw in other household members to either look after them or give them support to help them run a business or something like that. And so that sort of is one of the reasons why I would try to investigate what happened to the households in the Halsey sample who got this massive increase in income. Again, I thought it was a very thought-provoking, important study. And thank you so much for inviting me to be a discussant. It was a really, really interesting session. And I'm very grateful to have that opportunity.
Thank you, Duncan. That was excellent and really thought-provoking. Okay. Comments, responses, questions?
I don't know who wants to start.
Well, you can start responding if you wish.
Okay. I would say firstly that I was really impressed by the quality of your feedbacks and the precision of what you mentioned. There are numerous interesting points. I will run your heterogeneity test depending on the rainfall distribution. I think it's a very interesting robustness checks to add. I also see the height as a new outcome of interest. I started to run some preliminary results on height, but height is misleading due to the fact that selective mortality may increase height, but in the meantime being reduced due to shock. So overall, the surviving sample may be higher or smaller. It depends. Very difficult to identify the true effects. And this mechanism have been documented in paper from Anne Case in particular. So I'm still on it, and maybe I will write to you to have other reflection on that. But thank you very much. It was very insightful.
Eleanor, can I ask you how you think about cognition and depression and how they're linked in this phase of life biologically? What do you think are the mechanisms here for those two things, similar or different?
Probably Mookie will respond also. You asked the question to
you.
Okay. Actually, I think it's very difficult to understand the causal effect of one on each other. And it's a good way for other research. And I hope that the collaboration between epidemiology and economics will help on that.
But I'm interested in the issue of the rainfall and how that, do you think there's a biological mechanism there that is affecting both cognition and depression, or there are multiple mechanisms?
Yeah, it's probable that inflammatory pathway may play a role, I guess, during infancy, during early years. But it's very difficult to understand those mechanisms, in particular in medicine, I guess. Regarding economics, I'm not well placed for that.
On to what I just mentioned as well. I think that was a limitation that I realized from my analysis as well. I mean, again, thanks so much, Prof. Duncan, for your very insightful comments. I think it was very helpful to know. I think like on the connection between depression and cognition, when I was trying to make sense of my findings as well, I think I mentioned in the presentation. So like if someone has pre-existing depression, their trajectory for getting a cognitive decline would probably be very different from someone who doesn't have pre-existing depression. And one of the underlying mechanisms is that there is a sense of imbalance in neurotransmitters for someone with depression. And I guess that imbalance could be triggered by what Eleanor shared in preview with weather shocks. I think in the Philippines, the weather shocks would actually be quite relevant. So either by life circumstances, weather shocks, I think that would affect the dopamine or neurotransmitter imbalance and that lead to maybe a higher risk in cognitive decline. Versus someone without depression, I guess, I'm not sure exactly the mechanisms, but from what I've seen in literature, I guess there is more structural changes in the brain rather than a more molecular shift in these kind of imbalances. Yeah, I think that's what I've gathered. Thank you.
Any other responses from the presenters?
Yeah. I'll go next.
Okay.
So Dr. Thomas, I appreciate you bringing up the interesting points. So I believe your first question was about the similar age or like hazard ratios across countries. And I believe one possible interpretation could be that the relationship between cognition and mortality may reflect fairly fundamental biological or health processes that operate similarly across populations. So even though these countries differ in many social and healthcare contexts, the association between cognition and mortality risk may still appear quite comparable, which is interesting, but at the same time exciting.
Let me
yeah.
just interrupt. Let me just interrupt. I think what was surprising to me, and there's two things.
Yeah.
What was surprising to me is that each one of the specific domains, they were very, very, very similar. But when you use the aggregate, the global domain, Mexico is completely different. So that was what I thought would be, because the first statement you make is that these are all fundamental constructs, which, is surprising because we know that the way that memory is measured is, a very different idea if you're very well educated and not very well educated, and you've got not very well educated population in India and Mexico, and the orientation questions are quite different, in fact. But let's just go with that those domains are very, very, very fundamental constructs. The question is why, when you aggregate them up, you get this dramatic difference in Mexico. That's a piece that is difficult to reconcile with that statement.
Okay. Thank you. Thank you for the clarification. I think I would need to look like more closely, look at maybe at the distribution of the scores, actually the aggregated ones in the MaxCog, to better understand why the why it's why the hazard ratio of it is significantly different from the other two countries, even though the domain specific one looks pretty similar. So yeah, yeah, maybe that could be my further like the
Well,
things that I need to see in the further.
what are the orientation scores in MHAS, say, versus HRS? I mean,
Actually, we all standardize. So it's a part of the HCAP assessment. So they
right.
yes, so they would have they use the similar items, and we all standardized the factor scores. So
but is there
yeah.
orientation like is there a question on the president or vice president?
No, it's not part
Not
of
in
yeah.
that.
Orientation only consists of like today's date and and country and state in Mexico as well.
All right. So there could be a difference in the importance of state orientation or something across countries that even though they've been in theory standardized, things could have a different meaning.
Yeah. Yeah, even though we get the CFA derived factor scores, that could be a limitation of
Right.
the study for sure. Thank you.
Buki, are you want to speak?
Yes. Hi, Dr. Thomas. Thank you very much for your insightful feedback. I think it's a very good idea to investigate the living arrangement during and after the program intervention. And it's doable. Both data set has detailed data collection on the household members. Yeah, thank you.
Do we have more questions or comments? Ralph, I thought you were waiting to say something.
I can jump in. Yeah, a lot of really interesting papers. Sangha, the work that you're doing reminded me of some other work that like Grant Miller and them have done on like the mortality minimizing BMI in different countries, right? And how like that's been changing across countries and across time. And I wonder, given how a lot of cognition is driven by these kind of underlying differences in health, we could see almost like the health to cognition relationships or the morbidity consequences of cognition map onto the mortality ones. And it'd be interesting to see if we can triangulate between cognition, morbidity, mortality, and if those things look different across the different countries too. And like I think Grant and them are doing work with similar countries, so you probably actually map across them fairly reasonably too.
Thank you so much for this. Yeah, I'm sorry. Yeah. Thank you so much for this suggestion and point. Yeah, I think it'll be this project is at the very early stage of the project. So I'll definitely take a look at like how and why cognition is related to mortality risk in each country and across how we can make it like the statement on cross-national comparisons.
You know, to that point, another thing that comes up is that you adjust for a whole lot of factors that include BMI and depressive symptoms and so on. And that may be driving why you're getting these very, very similar cognitive results for cognition. And so you may want to sort of look at that with a less fully controlled model and understand what those processes might be, how those processes might interact, which is not unrelated to Eileen's question about the biology linking cognition and depression.
Yeah, we can definitely do the stepwise like analysis for sure without any covariates and then demographic and health related factors for sure to see what makes that at what stage makes a difference.
Well, thank you, everybody. This has been wonderful so far.
So thank you everyone for joining. We go back to the session. So the workshop, thank you again for joining. We're to the last session, last but not least. So very interesting set of presentations today. So unfortunately, the first speaker was unable to join us. So we're gonna have 3 sessions. So you're gonna have 15 minutes each. So I'm gonna start with Zhengxiao Zheng from University of Macau. So whenever you're ready, Yang Xiao.
Okay.
Perfect.
Good afternoon, everyone. I'm Yin Chao. It's a pleasure to present our recent work titled The Association and Mediating Pathway Between Intergenerational Education Morbidity and Depressive Symptoms, Finding from High and Middle Income Countries. This presentation has 5 parts, including background, our research objectives, methods, results, and discussion and implications. The first part, our background. Let's begin with the global challenge. Depression affects about 1/3 of older adults worldwide. It leads to high morbidity and mortality, reduced quality of life, and increased healthcare spending. Identifying modifiable social determinants is thus a public health priority. Among social-economic factors, education is considered a fundamental cause of health. We focus on education for 3 reasons. First, it is measured more consistently across country than income or occupation in healthy and aging datasets, enabling cross-national comparison. Second, it is a clear target for policy intervention. Third, it acts as an early life resource that shapes lifelong trajectories of health and well-being. The figure on the right shows the older adults who did not finish secondary school have higher rates of depression. This pattern was found in a study of 18 countries. The key insight is that higher education is linked to better mental health. Rather than looking only at an individual's education, recent research also compares it with their parents' education. It is called intergenerational education morbidity. This approach captures the transmission of advantage or disadvantage across generations. The effects of education morbidity can be explained for several theories. First, resource substitution theories suggest that people from advantaged background can replace a missing resource like education with another, such as household wealth. Second, cumulative advantage or disadvantage theories. It helps explain the mental health difference. Our mobility may offer some protection. Adam and Eve means a group of people in different socioeconomic status. Stably advantage or disadvantage builds up over generations. Third, the fundamental core theories. Education acts as an upstream flexible resource, shaping access to material and psychosocial advantage across life course. This study uses a life course perspective. It looks not only at a person's own resource, but also at how early life conditions affect mental health in later life. However, earlier studies have three main gaps. First, most evidence comes from high-income countries. There's limited data from low and middle-income countries. Second, few studies combine both cross-sectional and longitudinal designs. Many also fail to adjust for secular trends in education across both cohorts without adjusting for widespread education expansion. It is difficult to distinguish morbidity effects from cohort effects. Third, the mediating pathway linking morbidity to mental health remains underexplored. Understanding how education operates through material, social, and biological pathways is essential for intervention designs. Our study aims to address these gaps, and I will talk about how we address these knowledge gaps in later session. The second part, our research objectives. We thought to examine the relationship between intergenerational education morbidity and depressive symptoms. Using harmonized data from cis-aging data, we have 3 specific objectives. First, to test both cross-sectional and longitudinal associations. Second, to assess whether gender moderates these associations. Third, to explore 3 possible mediating pathway: household wealth, which reflects socioeconomic inequality; social activeness, which reflects social connection or disconnection; and multimorbidity, which reflects biological embedding of disadvantage. The third part, methods. On the left, we show the cis-aging study we use. They include data from the US, England, European countries, South Korea, Mexico, and China. As you can see from the bottom panel of the figure, it shows we use data memory between 2010 and 2020. This helps make the results more comparable across countries. The black dash boxes show the baseline surveys. The red dash boxes show follow-up surveys. On the right side, the flow chart shows how we selected our samples. The cross-sectional samples included around 95,000 participants, and longitudinal samples included around 57 participants. As you can imagine, most participants were born the early 1900s and the 1960s. During these times, many countries expanded access to education. So it was important to measure relative educational mobility. We built mobility measures in 3 steps. First, we group participants by 10-year birth cohorts. It helped account for secure education expansion. Since we did not have parents' birth year, we used the participant birth cohort as a proxy for their parents. Second, within each country and birth cohort, we ranked education into 3 groups based on percentiles, low, middle, and high. Third, we compare parents and participants' education to create 5 mobility groups: stably low, downwardly mobile, stably middle, upwardly mobile, and stably high. The figure on the right shows how education flow from parents to participants. Most mobility is either stable or between 2 nearby groups. Large jumps across multiple levels are rare. Our outcome were depressive symptoms. We use CSD scale in most countries and in European countries. Each study used its own cutoff for depressive symptoms. We look at 3 mediators. Over binary, which makes our results easier to interpret and comparable. We collected household wealth, social activeness, and multiple mobility. Here we also list covariates that we are adjusted for. Our statistical analysis, we use generalized linear model for cross-sectional analysis and generalized estimating equations for longitudinal analysis. We test whether gender changed the results and did separate analysis for men and women. We then combine results across study using meta-analysis. For mediation, we use a GE-based causal mediation with bootstrapping. We also ran 7 sensitivity checks that include adjusting for attribution, using sampling weight, excluding childhood health, using absolute mobility measures, using a continuous wealth measures, and changing the reference groups and applying for a causal framework model. Our results. For simplicity, I will focus on the longitudinal sample. We can see age varies a lot across country. In China, participants was much younger on average. Gender balance also different. Most countries had more women than men, except for China. Other traits also varied across country. We had 5 education mobility groups. In all countries, the stably low group was larger than stably high group, so we also use stably low as our reference groups in later regression model. In cross-sectional analysis, we compare each mobility group to the stably low. In most countries, we saw a gradient pattern. For example, in the US, individuals in downwardly mobile, stably middle, upwardly mobile, and stably high groups all showed lower odds of depressive symptoms than the stably low group. The stably high and upwardly mobile groups showed the strongest protective effects. This pattern similar in the US, England, European countries, Mexico, and China. In the meta-analysis, compared to the stably low group, the odds of depressive symptom was 0.8 for downwardly mobile to 0.45 for stably high. The longitudinal analysis over up to 10 years showed a similar pattern. The effects were slightly weaker but still clear. It suggests that protective effect lasts over time. South Korea shows weaker results, possibly due to its rapid education expansion. Still, the overall meta-analysis showed a clear gradient. In European countries and South Korea, we found significant morbidities and gender interactions in longitudinal models. The protective effect of morbidity was stronger for women in some group, for example, in downwardly mobile and stably middle group. This suggests that cultural and institution settings shape how men and women experience mobility. The heat map shows how much each mediator expanded the association between morbidity and depressive symptoms. The x-axis shows the comparison groups and the y-axis shows countries and mediators. We have some interesting observations. Household wealth was the most consistent mediator. It expanded between 5 to 77% of the association. The highest proportion was in England and the US, and social activities expanded 4 to 30% of the link in England, European country, and China. Multimorbidity expanded 3 to 28% in all countries except Mexico. We conduct a series of sensitivity analysis and the results are consistent. The 5-part discussion. Our results align with early study. Upward mobility and stably higher education protects mental health. It fits with a life course perspective, ensuring that both generation education matters. But there was one difference. Some past studies found downward mobility harmful. In our study, it still appeared protected compared to the stably low group. This difference may be due to how mobility was measured or differences in study context. Also, our findings have clear policy implications from a life course views. Investing in fair education, like free secondary schooling for advantaged youth, can support upward mobility and long-term mental health. For older adults, depression screening should focus on high-risk groups, such as some in stably low categories. Also, we call for a sporty environment. Policies that support economic security, social engagement, and chronic disease care can also help reduce mental health risks. A multiple generation approach is key to reduce mental health gaps in aging population. We also acknowledge some limitations. This study is observational, so we cannot prove causal associations. The measurement limitations. The parental education was reported later in life. It may lead to the recall bias. Also, some cross-national comparisons. The depression measurements still may differ across countries even after harmonizations. Language, culture, and familiarity with testing may affect scores. In summary, this large cross-national study shows that higher intergenerational education mobility is linked to lower depressive symptoms in middle to later life, and we found a clear gradient and some gender differences and multiple mediating pathways. Thank you for your attention, and I'm happy to take any question later.
Thank you, Jing Zhao. Perfect timing. Appreciate it. So you can please stop sharing.
Okay.
So thank you. So we move on to the next presenter. So for the next talk is Fernando Rios Mena from University of San Antonio, Texas and San Antonio. So whenever you're ready, Fernando.
Thank you, Iram. Can people see my slides and hear me well?
Mm-hmm. Yeah.
Okay, great. Thank you very much for accepting our submission. We're excited to share this work and appreciate it, especially in the context of the fact that this work is not only on the population that lives in low and middle income countries, but that are from low and middle income countries, right? So this is a project that aims at understanding the life course exposures and disadvantages that Mexican immigrants experience in the United States, but in which we have are trying or we're comparing with the outcomes of people that remain in Mexico or return to Mexico. This is, as you can see, joint work with many other colleagues, including David Lee, who's in the audience. Hi, David. All right, so we know that among immigrants, even despite the fact that there's this idea of a Hispanic health paradox, right? That especially in mortality, especially in cardiovascular mortality, Hispanics tend to have higher life expectancies than many other major race ethnic groups in the United States. This is especially an activity advantage in which immigrants display a larger advantage even though US-born Hispanics tend to exhibit, higher life expectancy, lower mortality than expected, given what we know about socioeconomic status and health, and given their socioeconomic standing in society, in U.S. society. Now that advantage, though, occurs in the context of some disadvantages, many other disadvantages in cardiometabolic health, in disability, in cognition, in general, but especially in terms of a deterioration, right? In a broader crossover, right, in which Mexican immigrants or immigrants from other parts of Latin America, especially South America, actually, which is a whole line of research, I would think. But Mexican immigrants in particular tend to exhibit, right, this oftentimes favorable, for example, disability in early midlife, or especially around early adulthood. Approaching mid adulthood is when you start seeing that crossover, right? That exists even though they experience or exhibit, more advantageous survival, right, in old age. And related to this, right, disadvantages and advantages, right, social gerontological work, disparities research point to different kinds of life course exposures. And for immigrants, this translates to examining pre and post-migration experiences. And two types of exposures are particularly relevant. I'm sorry, the ringing the bell, but pardon, I'm going to ignore that. Two are particularly relevant. One is childhood SES, and the other one, legal status in the United States, right? So pre-migration, experiences that are related to experiences in childhood, as well as post-migration experiences related or encompassed by legal status being as some scholars have called it, like a major axis of disadvantage. So the aims of our project are to examine mortality patterns in particular, but in the context of the examination of other patterns of health, including disability, that I can speak to in the Q&A if there's time, but in which we are examining the outcomes of Mexican immigrants in the United States, along with those of key populations in both the US and Mexico, for both methodological, artifactual reasons, as well as to understand important counterfactuals, examining the role of pre-migration childhood, SES, and health. And on the post-migration exposure side, looking at two important proxies. One of them is a likely legal status, as I'll explain in a moment, how we exploit or how we do this, as well as age at immigration, right, being an important marker of exposure to U.S. society and the timing thereof. Okay, so the basic approach we take is using data from both the HRS and the Mexican Health and Aging Study. Both of them have been referred to at least a couple times throughout the day. So I'm gonna obviate a longer description of them, and simply say that we use participants whose first interview, occurred in 1998 for the HRS, and 2001, which is when the MHAS started, or later. All the way to 2020 or 2022, I forget. My apologies, but I think it's 2022. The HFR's interview, of course, more than 50 years old, participated in at least 2 waves of interviews, or has a record of death, of year of death in the second or after the first baseline, otherwise, right? no missing data on key variables, and HIV first U.S. migration. We have very few cases, but we excluded individuals who migrated during very or somewhat older adulthood above age 65. We study death as the main outcome, meaning survival through the last year of observation, using survey attrition, not unlikely to be related to mortality, as a competing event and a competing risk setup. We have various important key race ethnic groups tend to be well represented in the HRS, including non-Hispanic whites, non-Hispanic blacks, both U.S. born. In both cases, we only look at U.S. born individuals. We also compare U.S.-born Mexican co-ethnics to Mexican immigrants. And in the MHAS, we make the distinction between the people who have never reported never having migrated to the United States, as well as return migrants or people with prior U.S. migration experience who live now in Mexico and are captured in the MHAS. We exploit the timing of the 1986 Immigration Reform and Control Act General Amnesty Program that provided legal permanent residence to eligible individuals where the main aspect of eligibility was people arriving and before 1982, before before 1982, and who had been continuously in the United States since. Is the main program people used. There were other requirements, including good moral character, good behavior, paying past fine and past taxes. But research suggests that the vast majority of people who applied, who were eligible and applied, initially eligible and applied, obtained legal permanent residence. So we use that as a proxy for legal status, right? So people that arrived before 1982 we assume that the vast majority of them are almost assuredly legal permanent residents. And then after that, people arriving after, we don't know their status exactly, but we know that there has been a much lower likelihood for them to be here legally in legal status of any kind, or otherwise in very great legal statuses, although not many for these cohorts of older adults. Right, and speak more to that in the Q&A again if there's interest. We also control for HIV migration again as being an important element of exposure, right? With research overall suggesting that the longer time of exposure to the U.S., the earlier people arrive, their health tends to be worse overall. But in which, as I'll show in a moment, there's some interesting interactions between legal status and or current legal status and this or cohort, right? So we'll try to disentangle this, or we'll discuss this a little bit. We control for gender, educational attainment, and other kind of life course disadvantages that might be determining life chances, including educational attainment, which is fixed for relatively early in life, especially for many of these folks and many of these cohorts, but in which we have some measures in childhood, and then in some additional analysis as well, some in adulthood, right, related to occupational attainment and health. And wealth. That I can speak to later. Some of the work we've done. Now the setup, the methods we use is a competing event Cox regression, predicting mortality as the main outcome, but accounts for survey attrition as a competing outcome. And we do different kinds of stepwise models that I can explain later on, but let me get to the results. So these are cumulative hazards by migration status, in which, as you can see on the left, this is the HRS on the left and the MHAS on the right, on the same scale. We see both pre and post IRCA immigrants, right? People that are more likely to have legal permanent residence versus those who are somewhat less likely to have legal permanent residence, have similarly low mortality rates relative to non-Hispanic whites on the left. So this is the classic Hispanic health paradox, except that we are showing that there's no huge differences between those people who have legal status and those who don't, which is consistent with some prior work, for example, by Hamilton and colleagues with the National Survey of Farm Workers, that suggests that people who are undocumented tend to have slightly better health than people who may be more likely to be documented among farm workers. But it's also inconsistent with other work that suggests that legal status, of course, can have very deep and later on in life, especially, right? So the farm worker sample is a little younger or somewhat younger than this one, with people that with outcomes like disability, for example, and cognitive impairment, where there's a deterioration that presumably is related to legal status as well, or in our case, in our project, we found evidence suggestive of that. Now, another so it's important, of course, to consider what the immigrants, face here, or their outcomes relative to those of returning migrants as well, right? Yeah, and so on the right, you see the MHAS sample, right? And you see that non-migrants are those who in the top, right? They exhibit higher mortality than return migrants, both pre and post IRCA. But especially post-IRCA immigrants here have lower mortality than pre-IRCA immigrants. I'm sorry, so non-migrants and pre-IRCA immigrants have very similar rates, I should say. And post-IRCA immigrants tend to have lower mortality than pre-IRCA immigrants. And these rates tend to be, however, higher than those of pre- and post-IRCA immigrants in the United States, right? So this has some implications in terms of salmon bias, potentially, although we can discuss at which point, because some of these immigrants, especially pre-IRCA immigrants, but to some extent post-IRCA immigrants, there's some of these folks here on the right that returned to Mexico long before their participation or their older adulthood. So it's a question, I think, to me that is important to consider. When might the attrition related to, or an artifact related to return migration is more likely to be relevant, of course. It would be after age 50, but we have some folks that return after age 50, but not a ton here. Nevertheless, you can see that the immigrants, folks that remain in the US, do tend to have lower mortality for various reasons. Now, what those reasons are, just to use the time wisely, I'm going to show you. We try different things and several models, but let me show you with a figure, right? So when we examine the role of age at immigration, we found out that for pre-IRCA immigrants, we see a very common approach, a more typical approach, which is that people who arrived earlier in life tend to have worse or higher mortality, right? So in this case, we're using the range from 20 to 30 years old of arrival, which is quite representative of the experience of these cohorts. And in which case, the people who arrive after age 20 in particular, sorry, at age 20 or so, have somewhat higher mortality than those who arrived at age 30, right? This is the typical thing you see in a lot of the health outcomes for duration of stay and age of immigration. However, for people who arrived after IRCA, and tend to have lower legal status or less likely to have legal status, the relationship is the opposite, right? Where people who arrive at age around 25, which is a more common lower bound, like, kind of quartile, I think, of the distribution, first quartile distribution, as opposed, and relative to those who arrive at age 35, tend to have lower mortality, right? So, and this is not explained, I should say, given that this is a session about SES in over the life course. There's very little in terms of the role. I mean, while pre-migration conditions, childhood, socioeconomic status in childhood matters for this, it's not a major factor explaining these relationships, right? So, I mean, we'll talk more about it in our exposition in a paper, but we think that the most important story here is related to this, flip relationship that is not only likely related to legal status, but to the selectivity of people, right? And not directly in the sense of post-migration experiences producing worse conditions for people who legalized earlier in life. In fact, we show in other work, again, I think some of it I presented here at some point, that disability rates, for example, are somewhat higher for those who are less likely to have legal status around the same ages, right, than pre-IRCA immigrants. So what we think is going on here particularly is different kinds of artifacts, right? So as per usual in this literature, one of them is return selection, right? So while return selection is important for both pre and post IRCA immigrants, we argue or we think that it's particularly relevant for post IRCA immigrants. Well, in terms of the advantage, right, that we observe relative to pre-IRCA immigrants, but the main explanation is likely related to the better health earlier in life from post-IRCA immigrants. We do see some evidence, for example, of better childhood health among post-IRCA immigrants relative to pre-IRCA immigrants. Some of these are differences across cohorts, but also, once we compare to non-migrants in Mexico with to the extent that we can, because there's only a few measures that are comparable across surveys. There seems to be a story there, but we want to articulate a little better in future steps or in the next steps we're going to do. I think I'm running out of time, so I'm just going to basically, again, mention that childhood disadvantage does matter and is a predictor of morbidity in particular, even more than mortality, but it matters. But this overall shows, as a last thing I'll say, that the longer but unhealthier life that immigrants, Mexican immigrants in particular, Latino immigrants experience in the United States is likely to be observed, particularly among those who are less likely to be documented. Or if you want, just making a little bit of a leap is among those who are undocumented. Thank you very much.
Thank you. Thank you, Fernando. Very interesting work. Looking forward to the discussion a little bit later. So we move on to the next presentation by Marina Gonzalez Samana from McMaster University. So Marina, whenever you're ready, start sharing.
Okay, thank you.
Taking a little bit to upload. Oh, there you go.
Okay.
We can see it now.
Move to the. Okay.
Perfect.
Okay. Thank you. Hello, everyone. I am honored to be here with such a group of experts. I am an international student from Mexico, currently studying at McMaster. So I would like to give a special thanks to Rebecca Wong and to the organizers, Eileen, Bill, Hiram. It has been truly enriching to be here, and I will present a study that is part of my dissertation. The analysis is still ongoing. So, okay, this presentation will cover these 6 topics. I will briefly start introducing a little bit the Mexican context, as I think it's important to frame the policy relevance of this study. As you may know, Mexico is a country of stark contrast. On one hand, we have one of the richest men in the world, and on the other, millions cannot afford their basic needs. Lack of access to healthcare services and social security are core features of informality in Mexico, affecting about 50% or to 55% of the working population, and are among the most common deprivations. Social mobility also in Mexico is very limited and is strongly linked to circumstances of origin. Well, with this inequality context, one particularly vulnerable group in Mexico is older adults. Many other adults in Mexico lack basic education, social security, or access to health services. So those without pensions or working in informal employment face the highest risk of poverty. These vulnerabilities have shaped public policy responses, reflecting, as we can see in this graph, in the increasing share of social spending in Mexico's federal budget, particularly through non-contributory pension programs and other social assistance programs. As I highlighted in the previous slide, lack of access of healthcare and social security are core features of informality and are among the most widespread of common deprivation in Mexico. Access to health insurance is mostly tied to labor market status with a fragmented system of social security, public programs, and private providers. As a result of this, many individuals remain uncovered and without, and as we can imagine, out-of-pocket and catastrophic expenditures, health expenditures remain high, particularly in those most vulnerable and those low-income households. We have been talking about this during the conversation. As many other countries, Mexico is experiencing a demographic shift, but this shift is characterized not just for this rapid population aging and increasing life expectancy, but also for a declining fertility rate. So as a result, we have a growing share population of elder adults with more NCDs, increasing health needs and placing growing pressure on an already fragmented healthcare system and unconstrained public finances. At the same time, fertility levels are now below the replacement rates, which are expected to reduce the working age population. So these pressures are compounded by high informalities, I mentioned, which limits the contributory base of the social protection system. As a result, fiscal space in Mexico and like in many other Latin American countries remain highly constrained as a growing share of public resources is absorbed by pensions and social assistance programs, restricting the government capacity to expand other policies and raising important intergenerational equity concerns. Well, one of the policies that in particular are being key in this arena is the tobacco control policy. As you know, tobacco use is a leading preventable cause of death, responsible for over 7 million of deaths annually. An important part of the smokers live in low and middle income countries, even though in Mexico, Mexico was one of the first country in Latin America to ratify the WHO Framework Convention on Tobacco Control in 2004. According to the literature, implementation has been weak and smoking prevalence has changed a little since 2009. This slide is just to show some of the main tobacco control policies implemented in Mexico between 2004 and 2025. At the end of last year, the Mexican government approved a reform increasing tobacco taxes. Okay, what we know about this literature and what are the gaps? So although research shows that smoking cessation remains highly beneficial at older ages, cessation programs still tend to focus more on younger adults. Research on smoking cessation among older adults remains limited, and most of existing evidence comes from high-income countries. In addition, studies linking life course socioeconomic status to smoking cessation are scarce and are largely grounded in epidemiological life course framework, while as we have seen in the presentations, there is another growing body of research, particularly from health economics, that show that early life socioeconomic conditions influence health and smoking behaviors. So, but mainly this evidence or the studies in this area also focus in or are also based in high-income countries. In this broader context, shaped by deep inequality, increasing pressure of public finances, this study considers this main objective, in particular, to explore the association between life course socioeconomic status and smoking cessation among other adults aged 55 years and older, and to explore whether this association varies with age or not. So these are the expected contributions of my study. I'm not going to click. The data that I'm going to use is the Mexican Health and Aging Study. This slide is just to show how the study sample was derived. The final sample includes around 3,457 individuals who reported being smokers at their web of entry, where at least they were at least 50 years and older, and completed at least two waves in the study. For the construction of the life course SES, we use retrospective childhood variables, referring to conditions before age that we have in the MHAS. We follow two approaches based on prior studies. The first approach considers exploratory factor analysis and confirmatory factor analysis, and the second approach was used more as a sensitivity analysis. That is, it was used in the work by Torres. At the end, we will have these four categories of SES for each of the two approaches. Regarding the outcome of smoking cessation is defined as the first of cessation for current smokers to non-smokers between consecutive waves. Independent variables were selected based on the existing literature, previous longitudinal studies, and a quadratic term was included to allow nonlinear relationship between age and smoking cessation. So we follow this progression. I will just focus on model 4. This study estimates a mixed effects logistic regression model with an interaction term between age and life course SES for exploring how life course SES trajectories and age influence the probability of smoking cessation. Results are presented in average marginal effects and predicted probabilities. Sensitivity analysis was conducted, again, running the 4 models and using the other approach by Torres et al. This is just to give you a very broad overview of the my descriptives. As we can see, about half of the reported experience first cessation event during the follow-up. Smoking cessation was more common among other individuals with comorbidity, those that smoke fewer cigarettes per day, and those with started later. So these are the results. We can see SES gradient compared with persistently high SES individuals, downward or persistently low. We can also, as expected, age increases cessation, healthcare contact helps, doctor visits help, higher smoking intensity lowers quitting, later initiation also helps. So I think in general the results are consistent with previous literature. The table shows whether the gradient changes with age. Socioeconomic gradient in smoking cessation seems to persist across older ages. Individuals with downward or persistently low trajectories consistently have lower probabilities of quitting than those with persistently high SES. Although the differences are modest, it remains stable, suggesting persistent socioeconomic inequalities in smoking cessation that may accumulate over time. So these are the predictive probabilities. Differences in smoking cessation emerge after around age 60 and widen with age. Individuals with persistently high SES show earlier and faster increase in cessation probabilities, suggesting delayed cessation among disadvantaged life course SES trajectories. Overall, life course socioeconomic trajectories appear to shape timing of smoking cessation in later life. So this is the same graph, but using the SES from Torres. As we can see, well, I'm not showing the average marginal effects, but the results are in general consistent with the confirmatory factor analysis SES. And well, as maybe we already have seen these or findings again, highlight 2 critical intervention windows: intervention in early life that reduce the likelihood of smoking initiation, again, factors such as smoking intensity, age at initiation, health status, healthcare contact also appear to be important, correlates with cessation. Maybe some important policies will be consider adults as a priority group in smoking cessation policies, considering broader determinants of health, access to healthcare services is still a major challenge in Mexico, as I showed at the beginning. Age at smoking initiation and smoking intensity are important elements of cessation success. Again, tobacco taxes are the most, evidence shows, are the most cost-effective way to reduce tobacco use, especially among the youth and the low-income groups. Studies have pointed that tobacco taxes could reduce consumption, raise revenue, and ease pressures on the healthcare system, also on the public finances. However, tax reforms in Mexico have been mainly revenue-oriented and not earmarked. Tobacco taxes help reduce early access to cigarettes, and studies have highlighted that policy impact depends on strong governance, multi-sectoral collaboration, strengthened rule of law in Mexico. So maybe framing tobacco control not only as a public health priority, but also as a public policy relevant for economic development, fiscal sustainability, and intergenerational equity may increase its prioritization within the government agenda. So thank you. I have this is, as I mentioned, this is still research ongoing. So some limitations, maybe some future research. As we know, MHAS is not a tobacco-focused study. Childhood SES indicators rely on retrospective reports, although there are some studies that support their validity. Attrition is not explicitly accounted in this study, and there is no clear agreement on how to define smoking cessation in the literature. Future research, including biochemical validation, examine how emerging other nicotine products are affecting different socioeconomic groups. So thank you so much.
Thank you, Marina, for your presentations, and thank you for the presenters for interesting work. So I want to transition now to the discussion. Thank you, Emma, for agreeing to provide some comments. So whenever you are ready, Emma.
Yes, thank
So,
you.
Emma Nichols from USA, sorry.
Yeah, sorry. Thank you. Everyone see my slides okay? Yeah, all right, great. Thanks so much to the organizers for inviting me to talk about these three really excellent talks. It was really quite fun to read through the slides beforehand and then to hear what all the speakers had to say. I think I wanted to just highlight a couple of like themes that stood out to me across the three different presentations. And I think the first one is the emphasis across all three of this life course perspective to health and aging, and thinking about the ways that SES interacts with health behaviors and health in older adults. This framework is one that I really like from a paper by Ben Shlomo and colleagues in 2016, and really just, I think, emphasizes how the factors that influence health really start at the earliest time points and interact with each other and accumulate across the life course. And I think all the speakers did a really great job of thinking about the ways in which we could operationalize these processes within the surveys and the data that we're working with. And particularly given that a lot of these studies start among older adults, it becomes much more difficult to think about how operationally we want to include these factors that we know are occurring over the life course in our empirical work. And it's I think, a challenge that we can always do better at, but something that I thought all three speakers did a really good job really critically thinking about and trying to incorporate. And then another sort of the big overarching themes that I thought linked across at least a few of the talks and was sort of came to mind over and over again was this idea around comparative evidence. So the first two talks in particular pulled from different surveys and in a comparative way, either sort of to answer the same research question, to answer questions about migration to the US and return migration to Mexico. And this framework comes from a paper on evidence triangulation that I really like, and sort of talks through some of the steps and things to think about when you're doing analyses that move across multiple different data sets, and how to think about what fair comparison means and what harmonization means, and across all the different components of the analysis. So thinking about the causal or statistical estimands that you're focused on, thinking about the exposure definition, the outcome definition, the population, and ultimately whether it's like reasonable to quantitatively compare estimates, or whether more qualitative comparison or a meta-analysis as Ying Chao implemented is the most reasonable way to consolidate evidence across data sets. So now I'll talk about each presentation just briefly in turn, and then hopefully we'll have plenty of time for a rich discussion as well. This figure was one that I really liked from Ying Chao's presentation on association and mediating pathways between intergenerational education trajectories and depressive symptoms. I really liked the use of the intergenerational exposure. I think this really, as I mentioned, like plays into this life course framework for the accumulation of health exposure to SES across the life course and how that influences health. I also really appreciated the attention to and accounting for secular trends in education through the percentile method, and also enjoyed the sort of comparative cross-national framework. I thought this is something that I think about a lot, is like, do we align measures or do we align constructs? And sort of thinking about the different cut points used on the CESD, as well as making sure, sort of taking advantage of Euro-D in share versus CESD in other countries. And I think it's always a question that you get from reviewers and other people, like, are these really the same thing? And sometimes we sort of do our best to get as close as we can, and in using study-specific cut points, and the binary depressive outcome, I think, is a really defensible solution in this scenario. I also appreciated the use of country-specific confounders and acknowledgement, I think, of different confounding structures based on sort of differences in population structure across contexts. And I also really liked the exploration of mediators as well. I think one thing that this paper made me think of is recent work that I've seen on sort of thinking about both the relative and absolute effects of education. So here, this was more with the percentile method, a measure of relative education. But I think both relative and absolute education are potentially really meaningful for risk factors. And this paper, this is just an abstract from I think the last GSA. So I don't think the paper is out yet, but I think this is really interesting work from Matteo Farina and colleagues, where they used both relative and absolute levels of education in models, and showed that there was, even when you put them in the same model, sort of significant effects of on both sort of scalings of education. So really, I think supporting the idea that they're complementary, very related, but distinct in some ways constructs. In terms of sort of questions and suggestions on this paper, I noticed a large proportion of the share participants were missing either their own or parental education, about 68%, I think. So that's, I think, something to look into and figure out sort of why that level of missingness is so high, and whether or not those people are different from those you retain in the study. Another thing I think you can consider is dividing share into European regions. I think you start losing, you start getting sort of too broad a number of comparisons and smaller sample sizes when you go to European countries. But I think there are sort of distinct cultural patterning by regions, and that's sort of maybe a compromise to at least explore. I think you could also use wealth as one of your mediators, and I think you could consider using per capita consumption or sensitivity with per capita consumption in LMIC settings in addition to wealth, just because some prior research has shown that it's sort of a better marker of sort of the economic patterning in lower middle income settings, because not all people have sort of incomes that are measurable in the same way as they do in high income settings. And then I wondered how sort of time was incorporated into your longitudinal models, given that I don't think the effects that you presented were sort of changes over time, but it did sort of encompass data across multiple waves. And then I think one sort of, future direction is nice thing about these surveys is that they're really broad and they cover a lot of different topic areas. And so I think there are a number of other mediators that you could consider, things like interaction with the healthcare system or occupation, that I think are also relevant. But obviously a huge body of work already going into this project. And so I think it's just a lot of ways to potentially extend in the future. Okay, so the second presentation I want to talk about is the presentation from Fernando on mortality and life course disadvantage among Mexican immigrants in the US. I put these plots here because I really like them. I think they're like a really great way to sort of descriptively show the results in the interaction between post and pre-IRCA, as well as the age at immigration, and shows it in a really compelling manner. So you see sort of the gradient here for the post-IRCA immigrants with lower mortality at younger age of immigration, and the flipping of the effect for pre-IRCA immigrants. And I think I really appreciated in this study the way that the authors used the policy change to characterize immigration experience. And I think it was sort of really compelling as well to include the comparison of the two country contexts to examine return migration. One thing, I'm not sure this is possible in the MHAS and HRS data, but I think there was a lot of the conversation around sort of what role is like selective return migration playing in some of these findings. And I wonder how if it might be possible using this data set or another to sort of better characterize the magnitude or rate changes in the magnitude or rate of return migration before and after the policy context, because you do see that flipping. I'm not positive this is possible in MHAS data, but it might be possible to bring in another data set to try to sort of capture that piece of the puzzle. I know there wasn't a lot of time to get into details, but I wonder sort of the quality of the measurement of childhood disadvantage. I know this is all probably recall in MHAS, and so it's another sort of thing to think about. You didn't see much movement adjusting for childhood disadvantage in these models, but I wonder if there's sort of like some residual confounding there. And then I really appreciated the way you brought up sort of some of the challenges with cross-cohort differences in early life experiences, especially given the pre-post design, right? We're always worried about sort of secular trends that affect the comparison group, particularly with regards to sort of childhood SES as a key factor here. And I wondered if it was possible to compare sort of neighboring cohorts around the cut point. This might be a problem or challenging if policy implementation is gradual, or if you just have a small sample size right around that cut point, but that's sort of one way to try to minimize the effect of those secular trends that we think could be sort of confounding that comparison. And then I'll move to the last presentation from Marina about life course socioeconomic status and smoking cessation behaviors in older adults. I really appreciated the rich description of the context and the framework, as well, again, the focus on SES across the life course, and really thinking hard about measurement with care and attention to that measure and the sensitivity analysis with a previously used measure. I think I would encourage even sort of further thought in whether or not SES is sort of a formative or reflective construct. I think this is something I think a lot about with measurement. Using a CFA sort of imposes more of like a reflective construct framework on the measure, but sometimes I do think SES in particular can almost be more of a formative construct where all of the different components of SES all sort of have unique important contributions that you want to capture in the summary measure, versus in the reflective construct, what you're really capturing is sort of the shared covariation between your different indicators. I have put this figure on here because I really liked it in terms of sort of thinking about these sort of marginal estimates that you used, I think, quite well to visualize the findings and communicate the absolute probability differences is, I think, really useful for interpretation. Just a few sort of questions and suggestions. You mentioned at the end, sort of talking about some of the challenges in defining cessation here as the first observed transition from current smokers to non-smokers. It's interesting to think about, or at least quantify, like how many people then went back, like what was sort of like the relapse rate, I guess you could think of it that way. Potentially do sensitivity analysis could be, requiring two successive waves to be qualified as having cessation. I thought I really loved the way you sort of framed the whole project in the context around some of the policy changes that have happened over time, but then they were sort of separate from the analysis itself. And so I wonder if there's any way to incorporate or consider those policy changes over the course of the study period and whether or not sort of they had different effects by SES. I don't know if there was the data will support an analysis like that, but it's just, I think, something that came to mind given sort of your really rich contextualization of the context. And then another, I think, point, smoking cessation in older adults sometimes attributable to diagnoses of smoking-related conditions, and this sometimes leads to sort of counterintuitive observations. And this was another thing that I sort of wondered how it sort of played into your framework and the way you're thinking about interpreting the results. And then just a final, I think, very small thing, survey weights and longitudinal data analysis, I think, are not always straightforward, particularly when you're sort of pooling people across different waves. So people's baseline waves are at different times, and typically survey weights are constructed to make a single wave representative of the national population. So I was just wondering sort of how those were integrated into your analysis. And I think it's sort of a broader topic of conversation for the group as well. I don't think there's a straightforward answer to how to do this appropriately necessarily. And then I just want to end and conclude with some overarching thoughts. I think all three talks really illustrate how diverse study contexts like those used here provide really great opportunities for evidence triangulation and investigation into different types of exposures and factors related to socioeconomic status across the life course. And highlight the ways in which these different contexts and factors influence behavior and health. And I really applaud all three presentations for the care and attention that took to potential methodological challenges and considerations around measurement, life course, accumulation of exposures over time, and a comparative framework comparing across different contexts. So thanks so much, and sort of happy to have a conversation on these topic areas.
Thank you, Emma. Thank you for very thoughtful and detailed comments. Very much appreciated. So I think, like in the previous session, we want to open it up for any questions before we give perhaps the presenters an opportunity to respond. Any questions? Anybody? Anyone? No one wants to go first? Okay, so I guess I can go and start first. So thank you again, Emma, for very thoughtful comments. I wanted to ask a little bit more about Marina's talk, Marina, regarding the smoking. I wonder, you have looked at whether the smoking, in this case, is smoking cessation, but I just wonder, you have looked at any possibility that we see any cohort patterns in the smoking behavior in the Mexican population. We know, for example, in the US that smoking is very much on a cohort basis, at least when one links that to mortality. So the work that Sam Preston did a couple of decades showing the cohort trends on smoking and mortality. So I just wonder if that is the case also in the Mexican population, because from what I've seen data, smoking is not that common. So I just wonder if it is a very cohort type of behavior. So I think it would be quite interesting to look at it.
Yeah, I found like obviously early cohorts used to smoke more than the younger cohorts, for example. And what else? What else I found? They were less educated, the younger cohorts, and yeah. But in general, I mean, yeah, for example, regarding the attrition or the people that they are dying before I observe the event. For example, I haven't controlled for that. So yeah, that is still a limitation of this study.
Fernando?
Thank you. Yeah, a quick question as well from Marina. Very interesting research. Thank you. So I was fascinated, I guess, is a word to use by the results of why lower SES people have lower cessation rates. I understand that I was wondering if you thought of barriers that could explain, well, to an Emma's point notwithstanding, right? Are these people trying to quit, or are they sustained quitting behaviors? But assuming they are sustained, but even trying, right? I was wondering the following, which is, I'll try to explain very quickly. A few years ago, a colleague, Jason Boardman, published a paper in the American Journal of Public Health where he showed that the genetic influences on um, um, smoking were particularly strong, where policies were more in this case, U.S. state policies were stronger against smoking, meaning that the people that it's suggesting that people that smoked in places that is very hard to smoke because it's expensive, it's there's a lot of social control, etc., tend to have stronger, basically genetically predisposed to it. They're more addicted to it, so to speak. So I wonder if the people that are low SES and trying to quit, or sorry, that are low SES in general, tend to have maybe your the prevalence thing you just mentioned suggests that it's not, but they basically have a harder time quitting, and that's why they're less likely to quit. Or if there's any socioeconomic barriers you see to quitting that we should consider, or what's the explanation?
What I observed, for example, a lot of them, for example, didn't have like a health insurance, like a formal health insurance, access to health insurance. Yes, but maybe I need to explore more regarding how much of them relapse, or yeah. But in general, as I remember some of the graphs that I did at the beginning, or the chart that I did, I observed like those that have the more attempts were in the highest, those in persistent high, as far as I remember.
Okay. Will Doubt?
Yeah, while we're just on the topic of Marina, of your paper, I enjoyed it. Thank you. And I'm just thinking about potential extensions, as people have just been talking about. In terms of relapse, MHAS does have a question. Have you smoked cigarettes in the last 2 years? And so you can use that to get more durable quitting. But they also have this information on intensity. And I think you had mentioned that the low SES folks, I was just Googling around, and there's sort of a median of like 1 cigarette per day in some of the rural areas for some of the populations. And I wasn't clear exactly what subpopulation that was, but that's a very different behavior than someone who's smoking 10 cigarettes a day, or a pack a day or something. And I think it would be really fascinating to study intensity of smoking. And they also have a question, when you smoked the most in your life, about how many cigarettes or packs do you usually smoke in a day? So you can actually use that as an imperfect measure of reduction in intensity relative to their lifetime maximum, in addition to looking across waves, of course, at reductions. So I think there's a lot that you can do to keep building on what you have here.
Thank you.
Any other questions, comments? Anyone else? No? I don't know, the presenters want to respond briefly to Emma's some suggestions, comments that she provided. Fernando, maybe?
Sure, I can go first if you want me to. Thank you so much, Emma. Really, really great points. I really appreciated your reflection of all of the papers and this comparability across surveys, reflections, and took note on the couple of papers you mentioned related to this. Thank you again, and as well with regards to the suggestions you made to us and our paper, in particular the whether like the cohort differences that could be partially explaining this. We need to show them a little more clearly with regards to non-migrants, for example. But an excellent suggestion that we haven't tried is related to the comparing people that were, like the people that arrived right before 1981 versus those that arrived right after, right, but before 86, right, before we knew there was going to be an amnesty, bearing important, other changes in the way people were recruited or U.S. labor markets and so on, which, I mean, I need to think through, but I couldn't think of any specifically. Although there have been some important changes in Mexico with economic crisis that I should, try to think about as well. But these people might be similar, right, in some ways. We will also, in some of the work, we'll also include controls for health, in earlier in life, which tries to deal with some of the health selection to see how it reduces maybe the difference between pre and post-year immigrants. But we haven't done this with mortality in particular, so that's certainly something that we will try to do to address some of the points you mentioned. But thank you, excellent suggestions. Thanks for your thoughtfulness.
Thanks so much. Yeah, appreciate the talk. It was really nice work.
Thank you.
Thanks very much for Em's comments. For the several comments and questions, the first is about why we didn't divide the European country into several individual countries. We have several reasons. First, we analyze shares consistently with the design as a single multiple country cohort. So we analyze cell is based on cohorts. What's more, in shared this cohort implements unified instruments, sampling, and other measurements work across member countries. So, what's more, we analyze 5 category morbidity exposures. If we separate shared cohort into individual countries, may create several cells and yielding unstable estimates due to limited sample size. So that is the primary reasons why we didn't divide the shared cohort into different countries.
Just to chime in there on that topic, I definitely appreciate the sample size issue, and I think that's totally correct. I guess one compromise that I've done before is to split it into 4 regions, so like Northern Europe, Western Europe, Eastern Europe, Southern Europe, which obviously there's still heterogeneity within those regions, but then you sort of don't have as many of the sample size issues, and I think that could be a solution that's sort of like a compromise between acknowledging the heterogeneity and maintaining stability of estimates. So something to think about.
Okay, thank you very much. And as for the charms incorporated into our longitudinal models, I can share my screens again, and you may be clarify this question. Okay, in this in the bottom figures, we show the collected charms from 2010 and 2020, and the baseline is around 2012. At this time, we excluded those people with depressive symptoms, and we collected at least 2 waves of follow-up surveys. So due to the different terms of follow-up surveys, we measurement the time frame were around to 2010, 2020 to establish comparative between different cohorts. As for the third questions, we consider the per capita consumptions in our different countries. We check the household wealth divided by the square root of the number of household members, and so that we categorize into low and high household wealth groups. So the sales is the number of household members. So it made similar to the per capita consumption. Yes, that's all.
Thank you. Any other comments, suggestions for the presenters? Nothing else that comes to mind? Well, thank you, everyone. Thank you, Emma, again. Thank you, the presenters, for very interesting work. So I think that this is going to, in essence, conclude our workshop. I don't know if Eileen or Will have any last comments regarding the workshop, but we very much appreciate everyone for sending us your papers. A very interesting set of papers. We had a hard time actually selecting papers. They all were very good. Eileen?
I just want to say that every year the papers get better and better, and the discussants get better and better. So I think it's indicative of the work that's out there, and it's really a great occasion to have this kind of collection of papers, and it never would have existed even a decade ago, frankly. It's really amazing what's happened in terms of data availability and the sophistication of the questions people are asking. So I thank NIA for continuing to support our center so that we can continue to support this kind of work and this kind of day of presenting work.
I'll just echo that, and thanks so much to Hiram and Eileen for your help, and Jung Ki, and again, especially to our discussants, Emma and Duncan, who are here with us still. These fantastic comments and just so helpful for, I think, all of us. So.
Yeah, thank you, everyone. We're going to send you a short set of questions just in case you have any comments for the next round of the workshop that we are planning on having a year from now around this time. And please keep a look on the call for papers. We'll try to send them towards the end of the year, October, November, or something like that. In case you have additional work that you're still conducting, so it'll be great to have you back next year. So in the meantime, thank you, everyone. It was a pleasure to see you all, and thank you for keeping sending on your papers and keep the excellent work.
Thank you, Hiram.
Thank you, Eileen. Thank you, everyone.
Thank you. Thanks for organizing.